Can't find the building.
All right, we're good. All right, well, good morning, everyone. It's good to see everyone here that here in person and those that are in the video virtual world. We waited a little bit because we have to have quorum, and we're right at quorum today. And so if you need to step out, please let us know. I think there's a couple people that are trying to find this building, and then a couple people that are going to join us in just a little bit. But we're right at the quorum level, and so we'll go ahead and get started. One little procedural thing that for the people in this room, as we were noting and joking just a little bit ago, all these mics are live. You don't have the ability to turn them off, and so it will pick up whoever is talking and whoever has a side conversation. So just be careful about what you're saying, because it may be broadcasted and be on YouTube forever and ever. So with that, why don't we go ahead and get started, and let's do the official roll call.
Dr. Bobbito, Dr. Blader, Dr. Borges, Dr. Bryant, Danette Castle. Here. Dr. Chapa.
I can't hear you.
Carol, can you hear me? Okay.
Breaking up a lot though.
We all got muted. That'll help.
Dr. Farmer.
Dr. Farmer, can you hear us?
You're saying, Dr. Chapa, I'm here, but I'm sorry, I can't hear anything.
Can you hear now?
Oh, yeah, now I can, yes.
Okay. Dr. Farmer,
Here.
Dr. Goodman,
Here.
Dr. Harper, Dr. Ibrahim, Andy
Here.
Keller.
Here, I'm here. Dr. Ibrahim, I'm here.
And I'm here for Dr. Keller until about 11 o'clock. He'll be joining.
Okay. Dr. Lakey,
Here.
Dr. Liberzon, Dr. Martin,
Here.
Dr. Martinez,
Present.
Elizabeth Mayer, Dr. Mitchell,
Here.
Dr. Nemiroff, Dr. Newport,
Here.
Brittany Nichols, Brittany, I see Brittany. Okay. Michael Fitzgerald,
Here.
Dr. Pliska, Dr. Clutterwell. I thought I saw Dr. Pliska. Dr. Pliska? Okay,
He's here.
okay. Dr. Suarez? Dr. Taminga?
Dr. Tamming is here.
Okay. Dr. Thompson? Dr. Rowe? Dr. Wagner?
Here.
Dr. Wakefield?
Here.
Dr. Wesley?
She's not
Dr.
here
Will-
today.
Okay. Dr. Williams? Okay. Scott Blackland? All right, that's it.
Looks like Jairus Suarez just signed in.
Yeah, I'm here, just join.
Okay.
All right, so it looks like we have a quorum. How many people do we have?
Yeah, we do. We have quorum.
We can't hear you, David.
Okay, so we were checking quorum, and it's becoming clear that those in this room are going to need to talk really loud for the people to hear us. And so, again, apologize. We had to meet here versus our usual situation. And it's a combination of the hybrid meetings, which are always a little bit difficult, but we will press on and make sure we complete the business we need to complete today. Yeah. All right. So Carol, can you hear me okay now? Carol Dominga, can you hear me okay?
You're kind of a little bit
Yes,
in
we
and
can
out.
hear you.
All right.
You do keep going in and out, though.
All right. All right, well, we will go ahead and get started. It sounds like you can hear me. Scott Shacklin has signed in. I want to wait till we reposition the microphones. Okay. So let's go ahead and get started. First order of business, we need to approve the minutes from the last meeting. I think they were sent out to everybody. Any questions on the meeting minutes? If not, we will go ahead and approve them.
So moved.
So moved by Dr. Kaminga. Do I have a second?
Second,
A second by, I couldn't catch who did that.
Dr. Wagner.
Dr. Wagner, second by Dr. Wagner. Any further discussion? Seeing none, all in favor of approving the minutes signify by saying aye.
Aye.
Approved. Against, say nay. Okay, anybody abstaining? Okay, it's unanimous approval. But we have a busy meeting today, and so again, thank you all for here, either virtually or in person. It has been really, really busy for the team. And I know it's been busy for everyone out there in your institution standing up these programs. As we'll have time today to talk about the different things that have been going on. We've testified 4 times to the legislature within the last month and a half. And again, want to thank the other folks that have also testified. I've drugged Dr. Laurel Williams down to testify with me multiple occasions. Dr. Wakefield has been down there. We have also had a lot of media interest in our work. And so again, it's been really busy. And in the midst of that, we are putting together the budgets and readjusting the budgets and making sure that we best understand your needs and how do we get the funds out to you as quickly as possible. So with that, we will go through the items today, but again, want to start off with letting you know how appreciative we are of all the work that's been taking place over the last month. With that, why don't we go to the first presentation, Laura, related to communications.
Thank you. I'm Laura Cruzada, the Director of Communications for the consortium. My role is to maintain communication, consistent, effective, timely communication with our stakeholders for the consortium. While we have contractors and partners that work on program-specific outreach and engagement, my role is really to represent the consortium on outward communication. And so today, I'll be talking about a little bit about the Uvalde response and all the work that has come from that in terms of media. I'll go over just some small web updates and future activities. And so it'll be short and sweet, but if you have any questions, let me know. So as you all were working tirelessly and furiously to respond to the Uvalde crisis in a programmatic way, my team worked on putting up a statement. We got a lot of web traffic right after the incident because of not just media, but the governor's call out to the consortium in terms of resources for mental health access for kids in the state. So we put the statement on our website a few days later, both in English and Spanish. We also had resources that were pulled together by the COSH and all of your institutions that were vetted, and we posted those in English and in Spanish as well. The most traffic we got on our website during that time was to the T-chat page. And so each of the program pages not only had a Uvalde statement on the top, it linked to our response page as well as the resources. As Dr. Lakey mentioned, we got several media requests, both through the consortium and at your institutions. Just a reminder that if y'all do get calls from the media, just to keep us abreast of that so we can continue to track it. And similarly, when we get requests and there are questions about local responses, we've been forwarding those to your media team and specific providers. The status of that right now, as you can see, the consortium received the requests on the right-hand side. The ones that are highlighted from Texas Tribune, KXAN, et cetera, were actually stories that were published based on our interviews. After Uvalde, between May 25th and last week, the total reach, which means how many people saw it based on unique clicks on those websites for those media outlets, was 705 million.
Sorry, 705 million people got something about the consortium work
Yes.
over the last month.
And Jonathan helped me, but a big reason that is because other outlets pick up on the wire, these big stories from like Fort Worth Star Telegram or Texas Tribune and the like. Sometimes we were quoted, sometimes we weren't. The most mentions were about the consortium and T-Chat. We had a few specific outlets cover CPAN very briefly. The spikes you see are based on key points in time, such as whether the public officials were mentioning us, or if we were presenting at the Capitol or testifying at the Capitol rather, and then when media picked up the stories and then subsequent media picked up the stories. And then here's just an example of some of the stories that came through. We've got a spreadsheet with all of the different headlines and reach for each specific outlet. And if you are interested in that and want to take a look at it, it's interesting to see how many were picked up again and again. So lastly, we have web updates. Just to give you an idea, we've been posting careers, job opportunities on a new careers page on the website, which has a lot of the different openings for the ARPA projects and the like. Soon we'll have a page specifically dedicated to ARPA, which will talk about the specific enhancements for each of the programs. Later down the road, we aim to integrate a dynamic map where you can see which HRIs are doing which specific projects. And then the last phase of that ARPA page will be metrics. For future activities, we're targeting refreshing the website in 2023. To do that, we're going to be doing some strategic communications planning to identify our audiences. Because as you know, the program audiences are completely different from the consortium audiences, and we want to just hone in on how we can effectively communicate the work that we do and eliminate any confusion amongst parents or the public about what we're doing, and really, to that end, increase access to mental health resources in the most effective way that supports your programs. Are there any questions?
Laura, for the places that we, when we need to tell you if we've been asked or if we're talking about consortium and media, is it directed to you?
Yes, if you guys could let me know.
Via email and phone or?
Yes, via email or phone. And we also have a communications monthly report that we're going to be rolling out to the coordinators to make sure that they're reporting back what their activities are.
So it has been really busy. And again, thanks for everyone for the support. Steve Pliska, I know we've sent some things towards you. Laurel Williams has been one of our spokespersons. Dr. Wakefield has been one of our spokespersons. They want to hear from not just the people here at System, but the people that are actually the mental health experts across the state and these types of events. And so Appreciate that. Please let us know if you're getting contacted to speak about the work of TChat or the consortium as a whole, so we can keep track. And we just want to make sure we're organized in that approach and how we're trying to respond. Any questions? Hearing none. Melanie, let's go to you next.
Thank you. Good morning. Going to try to share my screen here. Can everybody see it? Yeah.
Yes, we can.
Thank you. Okay, so I am with the Center for Health Communication at the University of Texas at Austin, and we are supporting outreach and communication with CPAN at this moment. I wanted to just start with a reminder of where we are in our timeline and the work that we have been doing. So in the spring of summer, and summer right here, we're working on paid search, the video launch, continued outreach support, social media. Those are the key tactics and strategies that we are moving forward at this time. Last time I was at this meeting, the last meeting, I spoke about the beginning of our digital outreach. We should be live in about 2.5 weeks. And these are the series of ads that we will be using. All of the information that you'll see here in the digital strategies and in the next slide, which is about the video, promote the messages, the key messages from the research and the external evaluation and internal evaluation reports as well. So the data is saturated that way. And everything we're doing is to remind providers that it's easy to join. We will take work off of your plate in terms of the referrals. It's one business day. Things may be billable, that a psychiatrist will call you back in 30 minutes or at your time. So we keep using those same key messages in different formats for the saturation. So with the digital ads, we're going to be placing some on Facebook. We will also have some banner ads that will pop up based on where different people are located. We will be doing a statewide reach, and we're also working now to identify 4 target areas, priority areas that we will be focusing on. And there's, I'm in conversation right now with the external evaluators and our digital team on the different ways that we can highlight priority populations and work to get these messages to those providers. Let's see. Whoops. Okay, and then the video launch, we are moving into production. Production day is Friday. And again, this is promoting the key messages. The video will be one overview video that will last about 90 seconds. And then we're going to have 15-second cutouts, a series of about 5 videos that we can use in the digital outreach as well as in organic social media, which means that we can put it on a Facebook page, on LinkedIn. We can share it with the HRIs to be able to use as well. So those cutouts, which will be approximately 15 seconds, will be one key message. So there will be a 15-second cutout about vetted resources, vetted referrals, in one business day. There'll be another cutout about psychiatric consultation peer-to-peer. There'll be another cutout about gaining confidence from speaking with psychiatrists, and another cutout about the CMEs and Project Echo. So I'm excited about Friday and our production. We've also just sent out and met with the coordinators earlier this week to distribute some updated materials. they are even more updated than what you see here because this has the different logo, which has now been updated on the actual materials, but my slide was due before the logos got placed into the materials. So we have now distributed to all of the coordinators a revised general flyer that can be printed and put into the folders. It's a one-page back and forth. We have a revised bifold, which needs to be professionally printed. And we have told the coordinators that they can be in touch with Edith with Kosh to see about any kind of printing budget. We have a resource one-pager, which talks about the referral process, a new FAQ. We're working on a couple of additional materials, but these all have the same look and feel. They are to promote the statewide look and feel of a coordinated program. So they have all of the HRIs listed, they have the map, they have the main phone number so that this material can be used throughout the state. Here's a closer look at one of them. Let me see if you guys can see it a little bit better. So this is the FAQ, also which can be just printed and put into the folders. And I believe that Laura is going to put some of these materials on as PDFs on the consortium website for people as well. And questions? That's where I am.
All right.
Any questions for me?
I have a question.
Yes, ma'am.
Yes, Melanie, how do we get the, you said you're going to share both the digital and the paper with the HRIs. So how do we get those from you?
The paper materials, the files have already been shared with the coordinators. It is on Teams in a file also that they know where they can access it. If that doesn't work for anyone, you can be directly in touch with me or with Laura, and we can get the materials to you. The digital is not something that is shared. It is something that you will see as we go live in 2 weeks. It is posts that we put up and specific outreach that we're doing. So that I can share the ad file so you can have the visual, but I would I really don't want anyone to post that because we have a coordinated campaign for that right now. I am happy to also share the video once we are post-production. So we're shooting on Friday, then there's a long editing phase so that we get the 15 seconds exactly as we want. We will post those, I believe, on our website. The larger file, the 90-second, and then the 15-second ones, I would like them to come out in a coordinated way so that we might promote one of those key messages each month. So I could see us having, depending on whatever else we're promoting that month, that we tie in one of those 15-second cutouts with that. And we're happy to share those files as well.
Can you tell us, the HRIs, can you give us a little bit of advance notice about what you're going to be promoting in order to get us to coordinate with you and what your system is?
That is my hope. My hope is that I develop a calendar for the year because we're starting to reflect back on this past year and plan for the future year. And my job is to develop a calendar for the entire year that will have that kind of promotion. I'm not quite there yet, but that's what I need to do.
And you'll get it out to us.
I will. Yes.
Thank you. Good.
I would say that it will be in late September that will be out.
All right. Octavia?
Yeah, quick question. Just to be clear, will you be creating announcements like the Hog Foundation? We have our own distribution network that we could then put it into our mental health headlines and distribute it across the state based on almost like a PSA that you're going to develop?
Are you speaking of the video?
I was speaking of the videos and all the materials because we can distribute across the entire state of Texas.
we are working with different partners, and yes, I will do that. I will connect with someone from the Hogg Foundation to be able to do that. Yes,
Okay, that'd be great. I'll have our communications team touch base with you.
that would be fabulous. Thank you.
Any other questions or comments?
I will always make one last plug for our social media on CPAN. So everybody can join and follow the CPAN Facebook, Instagram, and LinkedIn to continue to organically grow the network and awareness of that program. So it helps when the Hogg Foundation follows CPAN.
All right.
Thank you so much.
Thank you, Melanie. All right, David, let's go to you.
Good morning, everyone. David Lynch from UT Austin, part of the internal evaluation team with Dr. Amalia Lopez, who couldn't be here today, but great to be with you all in person and online. I've got three pretty quick informational items. I don't believe they need any vote, but I'll just go through them real quickly. The first one, I'm going to share my screen in a kind of old school analog way. This is a report that was provisionally approved last meeting in May. It's the summary report for 20 to 21 biennium. There were a few updates that need to be made. They've been made and the report is ready for dissemination. If it hasn't been in your packets today, we'll be putting it on the website and be sending it out to everyone. So happy to announce that being completed. The second informational item, well, first I'll see if there's any questions on that from anyone. Okay, great. Second informational item is last year, the internal evaluation team conducted qualitative interviews with all the EC members. And we all know that that's very important input to gather. And so this year we'll be doing something similar by way of some online surveys to the executive committee members. So just kind of a heads up that we'll be sending those out relatively soon, probably next month or so, to gather that very important input on how the consortium is doing and opportunities for improvement, what things went well and things like that. So just a heads up on that. And the third item is that also an informational kind of heads up is that as part of our role, we'll be working with other internal folks like Kosh and Trait to do data validation efforts. There's a lot of data. There's a lot of ways to do data validation efforts, but just again, to kind of prime the pump that we'll be working on those efforts. And those can, again, can take different manifestations, but one way would be to pushing out summary data to the HRIs and having their data folks validate that that's what we have is what they have. And then there's kind of a feedback loop to looking at processing elements and making sure that everybody's reading off the same sheet of music, as it were. So just another heads up that that'll be coming down the pike. Any questions for the internal evaluation folks?
Not a question, but a quick comment. I want to thank you, David. You know, we've had a lot of data requests that we've pushed your way over the last month and a half as we've testified to the legislature, and just want to let everyone here know, you know, that the ability to collect that data and present that data, I think, went a long way with the legislature building trust of what we're doing and being able to show the number of people served in categories, being able to show the referral reasons. And I know Kosh did a lot of that, but David, I know you guys were also working with them to do that. And I think that paid dividends in building credibility for our program versus some other things that are out there that they don't have that kind of those metrics to be able to follow. So thanks.
Sure. Pleasure. Happy to help.
Mm-hmm. Any other comments or questions for David? Seeing none, let's now transition over to the external evaluation. Dr. Sarvis?
It's actually Dr. Peskin today. I think Dr. Sarvis might be out of the office today. So should I go ahead and pull up my slides?
That'd be great.
Okay.
Thanks, Dr. Peskin.
Sure. Oh, shoot. I just need to switch. Can you guys see my screen?
We can see your screen. Yes.
You can. Okay. Do you see the presentation?
Yes, it's in slideshow and we can see it now. That's great.
Okay, great. Okay, great. Okay. So we're just going to share a few quick slides about our activities in the past few months and our activities coming up. We've been working a lot in the area of trait data, and one of our objectives is to describe CPAN and TCHAT program reach and coverage across the HRIs. And at the beginning of year 2, we updated our logic models to ensure that we were covering all of the important metrics, and some of the key process and outcome evaluation metrics are reach, so number of PCPs enrolled in CPAN, number of school districts enrolled in TCHAT, and then service delivery. So how many PCPs are using CPAN at least once, how many students receiving at least one TCHAT, and then any outcomes that are not being captured through existing consortium sources, we are capturing through external evaluation surveys. And we have been putting together, we started these quarterly reports, and I believe we sent our first one back in May, which outlines all of these data metrics. We're also doing TCHAT and CPAN surveys similar to what we did last year. And the goal here, again, is to understand contextual factors influencing program engagement and implementation. And we've worked a lot over the last several months to develop sampling frames to really identify a diverse sample of school district campuses for TCHAT and clinics for CPAN across HRIs. And what we're trying to do is we're trying to get a good mix of campus and clinics who participated in the survey last year, and then also get a sample of campuses and clinics who are new for this year as well. We did start the TCHAT survey. On the right is our flow chart, and we've collected 130 surveys so far, and we're planning to open up the survey at the beginning of the school year to try to increase the number of surveys that we're getting. And then we will be sending out the CPAN survey shortly. We're also working to conduct interviews with CPE residents to understand their perspectives on program satisfaction, program challenges, the potential influence of the program on their professional development and future career plans, specifically related to, working in the community mental health setting. And we have conducted 7 out of the 10 interviews so far. We are also working very intently on developing our plans for our cost analysis. So our year 2 objective is to evaluate the cost of CPAN and TCHAT program implementation. And we've been reviewing existing data sources for obtaining the cost data, but also the last couple of months really working hard on developing instruments for obtaining cost time data that is not available through the existing sources. And so we've developed some surveys for HRIs. And then also we have surveys for the child and adolescent psychiatrists, and also the HRI program managers. And we just reviewed those surveys with Kosh last Thursday. And so our goal is to get those surveys out in the next month. And then we're also working on developing a decision analytic model for analyzing the costs and service outputs of alternative strategies for HRI delivery CPAN services. Another thing that we're working on is we're working with Dr. Cece Bauer to really try to understand reach and coverage by community factors. We did that this past year by looking at the social vulnerability index, but we're really working with her to identify even more specific metrics so that we can really understand the reach of CPAN and TCHAT across areas of Texas, and to really understand where the reach is based on existing measures of social determinants of health. And so our goal here is to create a dashboard to allow program planners to view CPAN, provider, and TCHAT school enrollment by factors comprising that geographic and social vulnerability index. And then finally, we're working on developing some packets for the HRIs to which include our results from year 1. And so we'll be developing those packets and distributing those packets soon, and scheduling calls with the HRIs to review those results as needed. So we've been very busy. We have a lot planned in the next couple of months, and we'll hopefully have some data to share with you at the next meeting.
All right.
And I think any questions?
Thanks, Dr. Peskin. Any questions?
I'd just like to say it's all very interesting.
Yeah, and really important. And we'll allude to this as we talk about the legislative hearings, but that cost analysis is going to be really important. You know, we got lots of questions related to the cost of our programs, and I think there's an understanding of you know, there's a difference in cost when you're ramping up programs versus when you hit steady state. But you know, this is something that they're going to be looking at very closely as we continue to do and move these programs throughout the rest of the Texas as per their direction.
I have a question.
Absolutely. Yes.
A couple of words on her slide kind of jogged my memory of the previous meeting.
And talk to the microphone if you could, just so they can hear.
The microphone. And the words were analytical model and trait and stuff. And I think one of the questions that was raised at the last meeting was around intellectual property. Like, do you have an update on that, or?
I don't think I have an update on that yet.
Is that going to be discussed later? Okay.
Not in this meeting, but we can take a look at it. And just priority wise, we've just been having to concentrate on other things. But we'll I see my good lawyer writing a note right now, and we'll follow up on that.
Because we're helping trade. Basically, my concern is we're helping trade develop a pretty robust platform with our data. And so
that's a very good point. Yeah, thanks, Alex. Any other comments or questions? All right, thank you very much. Let's go to the next item. And Luann, I don't know if you want me to start that off, or you want to start off?
Go ahead.
So we wanted to give you an update on your role and the role of the consortium over the last month following the horrific events down in Uvalde. And as I start this out, just want to make sure the members of this consortium know how grateful we are related to your flexibility and willingness to be of service to people, and putting off other plans in order to be of service to people. You know, the irony, one of the ironies of this whole situation is that Laura Williams and I was testifying that day to a House committee. We got moved up early because some other folks weren't there. And so after we finished, and probably about the time that we finished, was when everything was happening and the shootings were occurring. And then again, it's been a lot of interest in our programs and how we could help. For those of you that haven't been in this conversation, the local mental health authority is a block away from the school. And the federally qualified health center is about the same distance from the school. And they were in that really difficult situation where first they're they had high vacancy rates, under-resourced with people. They were victims because a lot of their kids were in the midst of that school, or they knew the kids because it's a small community. And they were asked to respond in the midst of that. And that's just very, very difficult situation. So the first request that we had was that the individuals working in the local mental health authority were having a hard time. And thank you, Steve Plitzka. You were our first component of our response, and very rapidly, within days, Steve was able to put together a team, basically one person per day, just to go and sit in the local mental health authority and be available to respond when needed and to kind of in an informal way, help folks deal with the grief of what's going on and decompress and have a safe place to speak. I think on the Friday after that, and then this was after Memorial Day, we got this kind of the second request from the folks at the local mental health authority that said that, again, that was extremely helpful, but they needed ongoing services for the next several weeks. 2 individuals a day to be there on the weekends, 4 people a day during the weeks. And did we have any way that we could think through of how we could provide that support? And so the folks at our institutions, thank you for responding to the email. We think we had 70 some individuals from throughout our medical schools and the HRIs that said, tell us when, and we will go down there and do whatever we need to do. The value of this was that it was hard in Uvalde with the number of people that were going on their own in an uncoordinated way to meet the need. And just having been in disasters, and in my old role, you really need to have a coordinated response. And so what we were able to do was give them a coordinated response that supplemented the people on the ground based on the needs and the things that they were asking. And so over the month of June, we basically rotated HRI by HRI. Sarah, I think Texas Tech was the first week, and you had folks that were there. Dell Medical School had a team that went down. UT Southwestern had a team that went down. And Baylor had a team that went down and took weekend shifts and took week shifts. A lot of them had to, because it was hard to find a place to live in Uvalde because all the media was down there and family was coming down for funerals. They couldn't find a place to stay, and we didn't want to take those rooms. And so your folks hoteled in San Antonio in a place that we found for them, or a place that they could find on their own, and then daily moved to Uvalde. And as I told folks, we needed folks to go down with a servant's heart. This wasn't a time to raise your institutional banner, and our folks, your folks, just folded in to supporting the local mental health authority and helping them through this really tough time period. And so we've gotten a lot of thanks from people across the state for what your institutions have done during this time period. We, as I noted, the FQHC was just a little ways away. They asked us then how we could support, and we worked with Texas Children's Hospital, and we were able to make an arrangement there for them to get some additional support there to help provide for the community. And so we have entered a new phase and have been able then to hand off that responsibility to the Bennett, again, thanks to the Texas Council, and handing it off to the local mental health authorities to provide that. But you guys really filled in a critical gap during a really tough time in a way that I don't think Texas had done before. And so just wanted to let you know how grateful I have heard people are for the way your teams stood up. And Sonia, I see your hand. Let me go to you, and then we can talk more.
Sure. Dr. Lakey, I'm so glad that you brought this up, and I just want to echo some of the things that you've already said. The support that the universities provided was definitely invaluable and greatly needed. As Dr. Lakey indicated, the LMHA is literally down the street from the school. So we know that each one of these type of situations, they're different. We never know how different it's going to be. But I, for one, have been so appreciative of the partnership with the consortia and with Dr. Lakey and Luann and Dr. Williams. It's a testament to how powerful and impactful we can be, working together and taking some of these resources that you all have been working on over the last couple of years. And I mentioned at the hearing that we jointly spoke at that it's really been a game changer. Having the support, of the university, like Dr. Lakey said, we've never had this before. In the past, we've always had to rely on the other LMHAs, to come and help. And for some of the reasons that Dr. Lakey mentioned, that just wasn't feasible at the very beginning. But now many of them have stepped in and are able to help. So again, I just want to echo my sincere appreciation for everything that you and your teams did in terms of, switching gears and providing that extra much needed support. And that support will continue. We have folks on the ground that are still there. They will likely be there for quite some time. We still have people in El Paso, as a matter of fact. So more to come on that, but it's been a great partnership. So thank you.
Thank you, Sonia. Danette, I see your hand also.
Yes, I just want to, take a moment. I'm still really emotional about this. So if I get tearful and just say, okay, move on, understand that. This has been, as everyone understands, a really intense time. And I just have to say to Dr. Lakey, to Luann Southern, to Dr. Williams, to Dr. Pliska, and everybody else who has been involved in this response, how deeply we are grateful. Sonia, for your leadership as well, and for your staff, how deeply we are grateful. The local mental health authorities have a long history of disaster response, whether that is a natural or man-made. And, there are different dynamics that occur around each one, but never before have we had the kind of backup and immediate resource and the actions that, were taken. Dr. Lakey in particular was very clear from the beginning that he would look to the Health and Human Services Commission for their lead and to the local mental health authority for identifying their needs. And so that just happened in a way that we are really grateful. I also would say that we've never had it before, and we've never needed it as much as we did in this particular situation. Not only, as Dr. Lakey described, was the local mental health authority within such close distance that they heard the shooting. They were, immediately recognizing that something was terribly wrong in their community. And only in, over the course of the next hours would they understand just how enormous it would be. We never had that resource, and we needed it really in this particular response in a way that I would say we've not seen before, even in major disaster responses. So thank you. We're very grateful. The workforce challenges in the rest of the state really impacted the local mental health authorities needing some time to be able to put together their teams to provide the support that they're doing right now in an ongoing kind of way. And that time was given to us because of your response and your willingness to have people go out and just figure it out in a really challenging and working it through at the moment kind of situation. So I just, on behalf of all of the local mental health authorities across the state, and in particular Hill Country Mental Health IDD Center, thank you from the bottoms of our heart.
Thanks, Danette, and thanks, Sonia. Yeah, again, any success was based on the willingness of your teams to put aside all their other plans, hop on airplanes. Luann sending out information to you, and you sending the information back, and us figuring out the schedule and the logistics and the housing and everything else Luann took place, to help take care of, and your teams helped to take care of. Yeah, a lot of the teams stayed in San Antonio. Some of the feedback that I've gotten was that was actually very good, because they needed that hour drive just for their own decompression after being there. And sometimes you had an extremely busy day, sometimes not, but that's how you have to be flexible in the midst of a disaster. And and base what you do based on what you're hearing from the local community on what they need. I would also say that what you did, again, has been seen, I think, by the state as being very effective. And I imagine we're going to have other conversations with emergency preparedness people here in the state of Texas to say, when the next hurricane comes in, when the next other big disaster comes in, how do we leverage what you guys are putting together to be officially part of the state disaster plan? And so those will be conversations we'll have in the future. But for now, again, thank you for what you've done. Uvalde was not a community that we had stood up TChat in yet. Dr. Pliska had partnered with the local mental health authority in the past. We had worked to bring them on. Oh, sorry, my computer just did something funny, but we had worked to with the ARPA dollars. That was part of the plan of rolling it out, but that just hadn't happened yet. But Steve is working now with the community, and Steve, I don't know if you want to say anything, but they will be, if you're part of the ongoing support we're going to be able to provide them, will be through TChat and other things that we're putting together. Steve, you want to say anything about that now?
We've had some extensive discussions with the head counselor for the Uvalde School District, and the MOU will go to the school board at their next meeting. And once that's executed, we'll probably first thing we'll do is kind of a needs assessment in terms of to kind of get us some anticipation as to how many individuals they may want to refer. I was actually impressed by the fact that the Uvalde School District has 5 full-time LPCs on their staff, which will be a big help. And there are also a number of other agencies in town that will be there. So it won't totally fall on TChat itself, but it is possible that the number of referrals could outstrip what we could handle with our current staff. And then of course I'll come back to David to see what we could do to expand other or have a call in other sites possibly to help out. We have our CPE programs with Hill Country. We also, separate from TChat, we've had a long-standing contract with Hill Country for our general psychiatry residents, so that we keep in close touch with Chris Stenke, the medical director there. So we actually have dealt with some of the sequelae of this event, through those programs, and so we'll continue. I mean, next big step is as soon as the MOU is executed, we'll be ready to move and get into action.
Very good. Thanks, Steve, again for all you're doing. Any questions or comments from anybody else around this table? But Luann, you want to say something?
I just personally want to thank all the HRIs who responded. As Dr. Lakey mentioned, we had almost 80 individuals who were prepared and stood ready to go to Uvalde immediately. And Monet Thomas and I sat and coordinated who would go in. And thank you, Monet, for all your help on that too. The logistics of this were, well, we got it done. Let's just say that. We were working fast and furious to make sure that we could get people where they needed to be, when they needed to be there, and it worked. I also would like to thank UT San Antonio. They lent 2 individuals from the university there who had provided us with incredible help getting hotels. And so I want to thank them as well for their efforts. And wanted to just mention too that we are hoping to have a Zoom or Teams meeting with all of the responders from the HRIs and all of the individuals that were involved in logistics so that we can have a debrief and talk about the response, what went well, what challenges were faced just in terms of the response activities, our logistical planning, et cetera, so that we can learn from the response efforts and, be prepared. Hopefully we won't have a situation similar to this again, But as Dr. Lakey mentioned, should there be a disaster that occurs in Texas, that we can be prepared and learn from how this worked and improve on it. So thank you very much, everyone. I cannot thank you enough for your efforts and for your response. Yes.
Dr. Vo?
Just piggyback on what you just said there. You know, unfortunately, we probably encounter something like this again in the future. And in preparation for something like that, would it be wise for us to plan like the development of like a tired team type of deal that could respond in a rapid fashion versus trying to corral everybody together and you just have a designated team just deployment?
No, I think that's a good comment. I think disasters in Texas just happen, and we have a variety of disasters, once in a lifetime events that don't seem once in a lifetime, that they keep occurring in Texas. And so I think there's a variety of approaches, management approaches, whether having a rapid response team that can then go, it seemed to work well, rotating between HRIs. You can have a early plan and then a longer term plan. But I think that's why we need to debrief a little bit and then think through how do we, with this experience, develop that management strategy to be able to respond quickly. Okay.
And I will say in this particular instance, the fact that we were able to come up with a template for you to fill out, having clinicians who were bilingual was essential to this response. So that was also extremely helpful and something that we will make sure that we continue to look at in the future.
Okay. Any other questions or comments? Dr. Wakefield?
I just have a comment that Dr. Pliska would be happy to help, and if you have exceeding referrals for your team.
Appreciate that, and certainly we won't hesitate to reach out if it's necessary.
So I guess the other part of this is moving forward. Chance Freeman, who works for Sonia Gaines, has basically been living down there most of the time since the shooting. He is the point person for the governor's office to put together a grant, and he's meeting with the community weekly on site with the different stakeholders to put together their long-term plan that then will receive funding over the next several years to organize that response. And then our role is then figuring out how do we plug into that those funds don't need to come to us. The legislature has been very generous in funding what we need to do, but there are other components of the response they're going to need funding for, and that's part of what Chance and Sonia is working on right now. And Sonia, I don't know if you want to talk about that at all, or if there's anything you want to add. If not, that's fine too.
Yeah, there's already been some dollars that have been directed to the Uvalde community, $5 million from what they call Victims of Crime funding that comes from the governor's office. And those dollars will be used to continue to staff what they call the Resiliency Center. It's a center that has been set up with multiple service providers, including our local mental health authorities and other type services, including access and eligibility. So there's food and other kinds of resources that are available there. So those dollars are going to be managed through the DA's office. And I know that they're taking applications. Chance has been actively involved in that process as well. And then there's some additional dollars that some of you are aware of, and those dollars were directed by the governor's office. Another $5 million. No, it's more than $5 million. It's several different pots of money. The dollars that affect us are we're going to be standing up multi-systemic treatment teams, as well as expanding coordinated specialty care services. And then $5 million that is allocated towards the LMHA and Hill Country to do planning in terms of, determining whether or not they need a new hospital facility or other types of facilities to address some of the needs that they have there. So that work is well underway. My staff are actively working on contracts right now. The other thing last thing I would say, Dr. Lakey, is to someone else's point. We know that these circumstances, unfortunately, will happen again. I mean, this is not going to be the last time. And one of the things that Chance and I have been talking about is, now that we know that the consortia is an active partner in this, that perhaps in the near future, when things settle down a little bit, we can sit down together and talk about, how we work together in the future going forward, and so that we're not just reacting the way that we had to in this circumstance. So we're real excited about that as we move forward.
No, that sounds good. Thanks, Sonia. Any other comments? No. And again, we've been plugging into HHSC, working with the governor's office. Appreciate the governor's office support of the work that we've been doing in the midst of this. And it leads us into the next item, legislative updates. It has been very busy working with the legislature. As I noted, the event occurred on a day we were testifying, and since then we've had 3 other times that we've been called upon to go and testify, 2 to the Senate side, last week to another House committee. So we've done a policy committee and a finance committee on both the House and the on the Senate. I guess a couple of general impressions. Again, they are appreciative of the work that we're doing. I think we've talked about how quickly we've tried to stand up these programs. TCHAT right now covers 40% of the student population in the state of Texas. To say that we've gone from 0 to 40%, I think is pretty remarkable. But the legislature has been pretty clear that they want it available to every school in the state of Texas. And kind of the timeline that we've been talking through is trying to for any school that wants to have TCHAT, because there's some schools that have decided to go in a different path, that we're going to be working to have that done by September of next year. And again, in order to do that, it's going to take a lot of work. And we're having calls right now with all the health-related institutions. And I think from what I'm hearing is that is doable. There's some of your colleagues that are going to have some challenges, especially in some of the rural areas. But some of your rural colleagues are doing long road trips right now. Down in the El Paso area, they're doing this, Sarah, I see you smiling. We were talking about the road trips her folks are going on right now, going through these smaller communities throughout Southwest Texas and going to school districts with 800 people in them, kids in them, and doing multiple of those kind of school districts in the same day that it takes that in-person contact in order to get them signed up. But that's what it's going to take in order to get us there. So a lot of support, a lot of looking at the finances. So we're going to have to become more sophisticated with how we discuss the cost of these programs. If you look at the different presentations, as we've been able to gather more information, we provide some additional transparency with the cost. It's still a little bit of a blunt tool on our costs because we're kind of everything related to TCHAT divided by student population or number of people served, or everything, all funds related to CPAN and number of consults. And we know that there's other things that occur under CPAN and TCHAT that we need to tease out a little bit to get your cost per episode numbers to where they are. As I've told the legislature, those costs that we're presenting right now are very preliminary, and they're on the high side because we need to pull out some of those other costs. And there's variability between institutions that we're working on right now. And so those costs should come down. But again, we'll have to have that ongoing conversation with the legislature on those costs. But overall, strong support. They really appreciated, as I noted earlier, the ability, because of the work of your teams and the work of Kosh to have data and be able to report the data back to the legislature. I think, again, we need to continue to build upon that feedback and make sure we're giving them the data that they need in order to build the credibility and build the support of the initiatives. There's always tough questions during a legislative hearing, but again, I think overall they have gone well. And again, Dr. Wakefield, thank you for going, representing Texas Tech, but also talking about the work that we do as a consortium. And I've tried to do this in a way that I've tag teamed with Dr. Williams, with Laura Williams, where I have presented more of the administrative role, but allowed her to respond to more of the mental health clinical questions. And I think that's been a good partnership. But again, thanks everyone for that support. Carol, I see your hand, but I'm gonna go to Andy. Andy has also been down there testifying. Again, Andy, thank you for all that work and presenting presenting the case of supporting our programs and presenting the case of the new things that the state needs to do in order to really secure the systems that we need here in the state of Texas. Anything you want to add to this before I go to Carol?
Well, no, I appreciate it, David, and thank you for everything you and Luann were doing. I'm sorry for missing the earlier discussion. I think just a couple things to highlight. One is, we are so in the weeds on this, and I appreciate, our conscientiousness around costs. We're going to have some discussions later about the need to amp up our ability to provide even better clinical metrics and outcomes, because we need to show the impact of what we're doing. And there's some great discussions that are going on around that. But I think it's important for all of us to step back and just realize that what you all are doing and have done is remarkable. It is truly remarkable to have built during COVID an infrastructure that had already reached 40% of the children, school-age children in Texas, and now has the capacity to be leveraged more broadly. And I think most importantly, has the connections with our on-the-ground providers and our local mental health authorities, in our other school districts, and in our other, child-serving agencies, both at the state level and at the local level. And it's remarkable. And I think that it's hard in a tragedy like this to feel that, right? Because this is so horrible. It's still horrible what's going on with folks on the ground. Members of my team are there doing some training around trauma and grief. And it is, it's a whole other level of trauma and grief. But I really think that's important. And I think too, the ability to serve and help more people really is a reflection of that, the trust that's happening here, and the trust to work in partnership with our colleagues, your all's colleagues at HHSC, the funds that Sonia is going to be administrating, the funds that are going to go ultimately probably through TEA and others. I just think this is an amazing thing. And so I mostly want to thank everybody and just hope that you feel that, because, when we go look at other states, when we were very involved, supporting Senator Cornyn and others for the legislation that came out of Congress, which, is interestingly called the gun law, even though it has, $11 billion of mental health funding in it. That mental health funding is going to shore up the certified community behavioral health centers, which fortunately Texas, every one of our LMHAs, I think, except one, and soon it will be all of them, right, Danette? Our CCBHCs, and that's going to be a huge infrastructure help for us. But that sort of partnership, I think, is just, to me, I think the thing I want us to focus on. And as we go forward, in addition to data, I think we're going to have to talk about how these MST programs, the core mental health services going on through our mental health authorities, including the coordinated specialty care programs, which are also going to get wrapped up through this for early psychosis, can be more integrated with how we're thinking about what we're doing through TChat and the enhanced TChat. So I think that's going to, in addition to sort of accountability and being able to show metrics, I think being able to show coordinated, meaningful plans around how we work together, and then evidence of how that works is going to be really important. But the main thing is I hope you all feel really proud of what you built, and while tired and overstretched, I'm sure heartened by the fact that we're going to have the opportunity to make this even better and to really create something that, while we won't prevent, no one can prevent every bad health outcome. We can prevent some, and we will be able to we have prevented some, and we will prevent some more, and not just these very extreme things that are extremely tragic, like a school shooting, but the everyday tragedies where someone dies from suicide, where somebody dies from a homicide suicide that happens together, or where children get caught up in risks that could expose them to death from violence because of something that really we could have treated if we'd reached sooner and could have supported the family if we'd had more intensive supports. So that's, I think, the main thing I want to hit on. And I don't know if that's overly sappy, but it's what I think. And so, and David, was there anything more specific or less sappy you were hoping I would say?
I think that was good. I, anticipated that there'd be some sappiness in there, Andy, but not just kidding. So, no, thanks. And thanks for being down there and testifying and all those hearings. So Carol, I saw your hand up earlier. Anything you want to say?
Yeah, I just wanted to say a kind of a practical thing, but in the middle of a very moving conversation, so that this whole review has been for, the isolated HRIs. We've been isolated from each other and haven't had a common discussion. So this common discussion is really important. I'm really thinking about the financial assessment, David. And there are a lot of things that happened, and even some associated with like sending people to Uvalde. Maybe if we could have a kind of a common a budget to fill out, like Luann sent us before, so we can tell you all of the costs of each one of us, so that we can so you can make sure that all the costs are included in that when you when you give the information to the legislators. That was my only suggestion.
No, very good. Thanks, Carol. Any other comments or questions about what's going on downtown with the legislature in the midst of this? All right, I don't see any hands. I did add at the, Danette, I just saw your hand. Yeah,
Okay,
go ahead.
Yeah, I was actually hesitating before I stepped in because I felt like maybe we'd reached a place where it was time to move the conversation on. But I do want to follow up because I would like to also extend gratitude directly to Dr. Keller. Dr. Lakey, you're talking about the testimony that he provided, and he has provided testimony. He provided testimony in response to the mass shooting in El Paso as well, when there was a special select committee put together after that event, or after that tragic situation. And he did that again. And what I would say is he has a way of talking about these situations that I feel as though legislators and others who are listening, general public as well, can absorb and understand. When he talks about the fact that we can't prevent any other, circumstances, all circumstances from happening in the future, but that we can learn and understand and better respond, particularly when it comes to addressing the needs of young people and helping those who interact with them understand circumstances in which steps need to be taken early on to intervene. And now in Texas, we have the ability to do that through this infrastructure that has been built. We have the ability to learn from these circumstances, continue to build that out, including with the community mental health centers, the local mental health authorities in terms of their response. Andy, you raised the CCBHC model of care. That's important for us to continue to strengthen that as we move forward. But your voice on this, Dr. Keller, has been really important and one that we're grateful for because it's very difficult to figure out how to maneuver in a situation in which you don't want to create stigma for people who are seeking access to care, who have mental illness, and the vast majority of whom will never be violent toward others, but who are oftentimes at risk of violence and being victims of crime, but certainly understanding those circumstances that can emerge in which violence does happen, and what we need to do in order to at every moment that we can, change the trajectory of a situation so that we don't have a tragedy. So thank you, Dr. Keller. I hope you will continue to put your voice on this and continue to be part of the message that we send to decision makers as we move forward.
Thanks, Danette. Well said. So one of the other things that I think was nice about the hearings, and this wasn't coordinated, but it was nice to have TEA talking about how we're helping, and Sonia, the work from HHSC, and talking about how we're dovetailing, and a variety of other entities besides ourselves talking about the work of the consortium. And so I think that's good. Now, one of the things that leads to the third bullet point there in the last 3 times that I've testified, I ended up talking about workforce. And I did that because I hear from you the challenge that you have in hiring people right now. Yeah, as I noted earlier, Uvalde had about the local mental health authority had a 30 to 40% vacancy rate starting. And Danette, from what I hear talking to you, is that that's not unusual right now because it's just really hard to recruit for a variety of jobs here in the state of Texas, but in healthcare. But mental health is really tough when the mental health authorities are competing with some of their folks, their counselors, et cetera, with Walmart and Target and other places related to pay. And so we've tried to end all these conversations with a discussion about the workforce challenge. And we are trying to move that agenda forward. And I think it's resonating with the legislature. I would also say a quick thank you to Sonia and Octavio, to you and Danette Castle and a variety of other folks. Not long after this event, we had a group that met and tried to think through what we could do that would be creative related to workforce. Sarah from our team helped us put together a document based on some of her experience of being a social worker and the challenges of getting to where she needs to be professionally and all the credentialing, et cetera, that it's really costly in order to do. And so we've put together a document and we're still bouncing it around a little bit, but I think it's mostly there. We probably share it with this group of some of those thoughts that the legislature could think about funding that would help us move the workforce issue forward in Texas. Things like decreasing the debt that students incur on the front end. As my friend Octavio pointed out, it's not just reimbursement, it is actually decreasing the tuition in the first place, kind of like the military does to get people in with you pay back afterwards based on service. Things like paid internships where students can work at the local mental health authorities or in our programs or HHSC. Things like, again, that Sarah brought up, once you finish your training as a social worker, you have to get your clinical hours in. And if you're not working for a large healthcare system, you have to pay for those on your own, which can be $5,000 to $10,000. And correct me if I misspeak, Sarah. Yeah.
At the rate of a clinical hour, because you're taking an hour of a therapist.
Yeah. So it's based at the clinical rate. So it can get very, very expensive for several years. The challenge of having enough of those supervisors in the state of Texas, there's a waiting list to get people in. To things like how do we get people from other states to come and practice in the state of Texas and the licensing issues, to the issue of the local mental health authorities having to compete with Target and having a pay scale that doesn't allow them to recruit and retain the people that they need. And so we are trying to move those issues forward. There actually sounds like there's going to be a House committee hearing on workforce based on a variety of things that have been brought to their attention. So I think it's getting some resonance, and in the Senate hearings that also seem to get some play, that because they're hearing it from multiple people that they need to do something on this. So I see Danette, your hand is up, and then Steve, and then Carol.
You're muted, Danette.
Thank you. My hand was up because I forgot to put it down.
Okay.
Okay, sorry about that. Yeah.
All right. Steve, let's go.
Yes, I'm glad. I know we're going to address this in the ARPA item coming next, but I think this is going to be our Achilles heel, this inability to hire. We're trying to hire all these master's level therapists, both for TCHAT, the current TCHAT biennium funding, and the ARPA projects. It's like 13, 14 positions, and we're not even getting applications. And I've been told we've been doing locally here in San Antonio, LPC associates that don't even have their license yet are charging $100 an hour cash in getting it. And then when they get their license, they're starting to charge $135 an hour. Some of my psychiatry residents who are going into private practice are saying, I'm going to charge $325 an hour. And I talked to a colleague in New York and said, well, you're lucky because in New York, they're charging $500 an hour. And it seems extraordinary that those funds, but and also to add to the problem is that people are doing these telehealth practices where they essentially have zero overhead. They're doing it out of their houses. So the stressors of renting an office and hiring a secretary and having a scheduling system, which used to be the barriers that people with holding a lot of debt didn't want to go into, that's no longer an issue. A resident can say, hey, $325 an hour, I'm going to be paying off my debt with no problem. I don't need loan repayment anymore. So I think this is going to be a really big deal. And I think now there's probably a limited number of people who can pay that. And sooner or later, people are going to come back to working for agencies and working in the public sector. But we've just did a big increase for our master's level therapists, going up to, I think, a mean of 78 or something like that, up from 50 to 60. And immediately all the salaries in private practice just jumped ahead of us again. And, we're trying to emphasize, the need to serve the public, to be part of a mission and all those kinds of things. But this is really going to be a short-term issue, I think, and we're going to have to think creatively about how to do it. And in particular, all of our HRIs, HR structures have got to get real, and they've got to start, speeding up their hiring processes, being more flexible about salaries, or we're going to we're going to be in a world of hurt with all of this.
No, thank you, Steve. Carol?
So I wanted to say something about what we've been thinking about in response to the kinds of things that Steve was just talking about, which administrators in every medical school are thinking about. We have partnered with one of our closest state schools, UT Arlington. UT Arlington has probably the second biggest nursing school in the whole country. And they have like 200,000 nurses. They have huge number of nurses. And they mostly don't go into mental health. So we started with them a fellowship where we'll take between 2 and 4 nurses a year. This is for adult psychiatry. We haven't done it yet for child, but we're going to take 2 to 4 nurses a year and give them like a year-long fellowship in psychiatry. And we'll do it at our indigent care hospital, which is Parkland, and at our university hospital, so that they'll have a variety of experiences. We would hope to recruit preferentially to our own needs from these people that we train, just like we do for our residencies. They have all sorts of different nurses. They have all the way from MPCs down to regular nurses, down to practical nurses. And they have some LPCs that they have other people that they train as well. I think that it would be good for all of the training campuses to go to our hospitals that are training our workforce and make deals with them like this to train them in mental health.
All right. Any other comments? Questions? All right. Well, again, thank you all for the work that you guys have been doing on these issues. And we'll continue to push the workforce issue with the legislature, because that's what I hear from you related to the main challenge. And as Steve said, the Achilles heel of trying to get these programs stood up as quickly as we want and the legislature desires. With that, let's go to item number 4, updates on the activities related to ARPA. And we're going to start this. Linda, great to have you here. We have, as you know, in order to make this work, have partnered with UT Austin, and they have been incredible in bringing professionalism to management of these dollars. And it's good to have you here. And let me turn the podium over to you.
All right, let me share my screen. And I'll try to speak loud. Thank you. All right. I have a brief update. I wanted to let everyone know that we're waiting for the contracts, the executed contracts to come back from TTCB between UT Austin and UT System, but we're anticipating those to come soon. We have sent out 18 different drafts, contracts to all our subaward participants within the HRI programs so that they could start reviewing the terms and conditions to make sure when we're ready to have our executed contract with TTCB that they could follow quickly right behind us. And so those have been all shared through each of those, and all the budgets have been reconciled. Are there any questions related to the contract update? I have a little financial stuff to show next as well.
And Linda, it sounded like in conversations that we've had so we have that conversation with the Higher Education Coordinating Board. We need to get that moving forward pretty soon because of obligations our institutions are making in order to have that taken care of correctly.
Two common things that come up in theme when I meet with them monthly is one, the delays in the contract that's taking place, because that does limit their ability to negotiate an offer letter to new people that they're wanting to recruit. So recruiting concerns are hard enough for them. And then they are able to have pre-award spending, but they're not able to make offer letters. The second thing that's posing concerns for them is that with the pre-authorization that does well for them to kick things off, but as we near our fiscal year end come August, without signed documents, it's going to cause problems for transparency and be able to reporting those numbers on the SEPA. We will not be able to report those numbers up to the federal level if we don't have signed agreements between each of us. And so it won't show the amount of progress that we've all been working towards if we leave the contracts in draft state only. We need to get them executed as quickly as possible so that we can start aligning the programmatic work that everyone's doing with the financial data as well.
Okay.
I wanted to share that prior to us issuing the sub-agreements to each of the HRIs, initially when we were granted the funds from the state, one of the things that came back when all the budgets were submitted was an increase to TTAC funding. So we went up almost 9% in that funding. We kind of reshifted our priorities. Prior to the recent events that took back the Uvalde, we did see a greater need there. And so when we get all the programs going, more than 50% of our program will be devoted towards the TTAC initiatives. So I just want to make sure that you guys kind of saw the correlation, that there was a greater need already identified. With that said, the contracts that I have in place, there are a lot of many programs that are going on within each of the funding program areas. And so I just wanted to kind of share where those dollars went in percentages. And so these are part of the packages that everyone will have, but kind of looking at percentages of how the money is going to get directed to each of the programs and stuff. So I have one for the C-SPAN, the TTAC, and also the workforce concerns and stuff that we have. So that'll be included with it. So I'm really impressed with being involved with the programs, and I'm glad that was selected to participate. I'm looking forward to kind of seeing how we can align the financial information for the public community to let them know all the good work that each of you guys are doing for the citizens of the state. And so I liked, somebody had mentioned to supply budgets of what those volunteer efforts are at the state. I think oftentimes when we are showing citizens that we're there and present, it's hard to always align those costs with it. And sometimes it's the only way that they feel like we're not doing enough. And so I think that it's important that we always overlay the cost of what we're doing to everything that we volunteer with or just in our everyday work that we do. So thank you.
Thank you.
Any questions for me?
Steve, let's go see your hand go up in the air.
Just a real practical question. I guess I've begun to think about now that this is getting real. Each of these projects has metrics associated with it. Well, let's just take a program, say it requires that an HRI recruit 40 people a month. And if we report that in the first month we recruited 28, how is that going to be handled from a funding standpoint? Are you going to prorate the funding for, or how tightly will the metric performance be tied to the reimbursement and over what time frame?
So there's
Or
a
is that to
couple
be
of
decided?
ways. Yeah, so there's a couple of ways that we're going to have to show the metrics. One, they want to know a status of where we're at on each of the programs. They also want transparency to kind of see how those dollars align with each of the programs. So you're right, we're going to have to take a combination of supporting UT system with their programmatic piece and those metrics, and try to get creative to be able to not just show we spent X amount of dollars of the funding to date, but definitely how it can correlate to the different stats and stuff. So as we start collaborating together, my group will be prepared to try to help overlay that in a different fashion. So not just by counts with individuals of how many patients are being seen, but of course with the normal burn rate is what the federal agencies are wanting to see. They're looking at much higher level, just wanting to say that how many billions of dollars have they given each of these states and how much have they been spending. But you're right, we have that delicate balance to be able to align it to the different initiatives that you have and the people that you're touching. So we definitely will be working with UT system to how to make that transparency and share those back with the group as we come along with those ideas.
And related to that, if we're just not able to hire and we can't launch a project, I guess we would submit that we haven't spent anything and just leave it at that, right?
Right, but I think that it's also important that when we are reporting these things, that we are showing what barriers that we have.
No,
Because
we
that'll
would
get
say,
the attention.
we'd clearly document that, but that is a risk here because we're trying to, got to hire 24 people to do all the projects. You hire 20, that's pretty good, but that means somewhere something didn't get done. And you don't want to rob Peter to pay Paul, basically.
Right. Any other questions?
All right.
Thank you.
Thanks, Linda. Let's go now to, and Carol, I'm going to assume your hand is up from your last comment. If that's not correct, let me know. But let's go to Lachelle for an update on the overall administration here at UT system. And then Jonathan, I think you're going to jump in. Okay.
We're still waiting on the coordinating board to get our contract back. Even out, if you can hear me.
That's, yeah, there's not a microphone there.
I'll just say that, Sarah has been working with each of the institutions to gather the metric information that Dr. Pliska was speaking to, and we've been working on a template to get updates, regular programmatic updates on the ARPA projects. And Jonathan's been working on the financials, and obviously we've been meeting with UT Austin on the contracts and making sure that everything continues to move forward. But as we talked about earlier, we're still waiting on the coordinating board to get back to us. Once that's gotten back to us, we will move as quickly as possible to get everything in place. We know everybody's working on moving the programs forward in the meantime, but we also understand the barriers until we get the contracts in place.
Okay.
Yep.
Move that over here again. All right, in spite of that, we still are doing a lot of work to be able to hit the ground running as quick as we can and to, that's it. You want to take that microphone over there? We're having to, for those of you who aren't in the room, we're having to do musical microphones here a little bit. And a couple of them look like they're not in really great shape. And we're having to be creative and how do we make sure the microphones stay focused on where they need to be. But what we're going to do next is go through the different new projects that have come out of the ARPA funds. Again, a lot of work has taken place to be ready to get started as quickly as we can. And let's start off with the Perinatal Psychiatric Access Network and Dr. Wakefield.
All right, so just as a reminder why we are doing this, if you
needed a memory jog. The Maternal Morbidity and Mortality and Morbidity Review Committee came out with some recommendations in December 2020, saying that mental and substance use disorders are significant contributors to maternal death in Texas, and recommended improving access and integrated behavioral health care from preconception to 1 year postpartum. So we've been able to answer that call with the ARPA funding when in the 87th legislature, third special session, the language was added that we as a consortium may enhance CPAN to improve perinatal mental health services. So out of that is what we are calling PeriPan, is the CPAN expansion, sister program, identical service to really provide this consultation, clinician to clinician consultation in what is known across the country as a psychiatry access program. So just as a reminder, this is the CPAN network. If you look across the state, these are the regional areas, designations for each of the HRIs, and all of our health-related institutions here listed are participating in the CPAN project. Four of these HRIs were chosen, you can see on the next slide, to provide across Texas and in different regions the PeriPan service. So these are identified as the pilot sites. Because of the population in these areas, it is like rolling out smaller state programs for within Texas. But we are covering a large number of women who will become pregnant or and deliver and postpartum. Next slide. So we've been doing a lot since the last meeting, since May, and definitely a lot since February. And wanted to talk about, we've had some meetings with Lantana, which is our phone service, or some communication with Lantana. And we were waiting on a few extra details that I got last night to be able to talk with Lantana about what the expansion of these lines will look like across the health-related institutions and what additional lines are needed to expand CPAN and to deliver this PeriPan service. The trait, so we've talked with, trait is our electronic health record where we share across the HRIs and store a lot of data, and our ability to pull this data and demonstrate to the legislature how many calls we're getting, how we're answering those calls, how many are resources and referral related, how many are medication management related. All of that data lives in the trait system, and we will be utilizing trait for PeriPan. One of the things that we wanted to do when we launched CPAN, the trait platform was not ready. And so we were putting things in a different database and then migrating that over to trait, a fairly cumbersome task. And so really wanted to have the trait platform ready to go before PeriPan launched. And as I presented last time in May, we talked about that it is an integrated platform between CPAN and PeriPan, really will account for those kiddos, those teens, the people who might have, both be a child and be pregnant, but also I think it's important. I think my mic just went down. If you can hear me, it's back. Also, I think maybe just stand there, Nagla. No, I'm just kidding. But also important to recognize that while we're expanding PeriPan to invite obstetricians to call our line, that the American Academy of Pediatrics actually has more stringent and frequent guidelines for screening moms. And so it will be very common and likely that pediatricians who are already using our CPAN line will call for a question about a mom. And that's what we're seeing across the nation in the perinatal psychiatry access project. So really trying to integrate it for that user, that clinician who will be calling the line to not figure out where they're supposed to call and what they're supposed to do, but they just call us, right? They call the consortium, they call this access network to get help with their patients. So that trait platform is going live, and the enrollment will be ready at the very beginning of August, and then the clinician platform will be ready and training will happen in the second week of August. And so our launch date is really really relegated to when that trait platform is ready. And that continues to be in August. So we're still meeting our target month for launch. We've had discussions with UT System, Pop Health, and communication strategies. And a lot of the things that you saw up there for CPAN, we are working on creating for a peri-PAN as well. Same types of documents with the FAQ, general programmatic information, and that will be pushed out to our health-related institution sites, our pilot sites, by the end of this month is the goal, so that they can start using those and disseminating that information. We've had some discussions with the Infant Risk Center. So some of you may be aware of what the Infant Risk Center is. Dr. Hale and his team up in Amarillo at TCMHCC and the Department of, or in the School of Pharmacy, has been running for years a call line for questions about medication during pregnancy and during breastfeeding. And so when I was a psychiatry resident, Dr. Hale published a book, and you would get it and you would get the updates. And now it's an app, and there's an electronic database. So we're talking about how to potentially integrate that service, or at least, let people know that that service exists. So that we can build on the resources that already exist in our state to help and support moms when there are medication questions. Many of our team members went to the PSI conference that was just this last weekend, talked a lot about access programs across the country and what this is looking like, and best practices are emerging. So continue that conversation both with Postpartum Support International, which is what PSI stands for, really the founding group that was interested in creating some clinical services around maternal mental health, and then Lifeline for Moms. We are working on a contract for, and I think it's signed, almost approved, for Lifeline for Moms consultation, which is the group that came out of MCPAT for Moms, the original psychiatry access project line in the country, out of Massachusetts. And so we're working with them and talking with their group. They've been helping multiple states launch these perinatal access projects. So we appreciate their assistance. And then Jen Erdegi has been hired, or she's recently accepted. Her start date is August 1st, Master's in Healthcare Administration and undergrad in psychology. She's very, very energetic, very, very excited. So will become the point of contact for and work closely with Kosh and with myself and with the pilot sites to make sure we're all rolling this out in a collaborative and similar fashion. Next slide. So we've had a lot of meetings. I'm not going to go through each one of these, but wanted to show you guys since May, since our last meeting, all of the different meetings we've been having and the ones projected into the future. We have met individually and had HRI specific implementation meetings about what these programs will look like at each HRI and how they'll be launched. But we have, as I presented in May, our goal has been to really learn these best practices from across the country and to provide this integrated service for, to meet these challenges in workforce, so we're not creating totally parallel projects that just need more duplicate workforce, and for cost containment and for advocacy and to make it easier for that user who's calling the line. There are 2 of the sites who are not really fully integrated at our launch date because of local just things that are specific to their region. And so we will be visiting with them and working towards that integrated model and kind of seeing what that looks like over the next 6 months. And then we have lots of trainings coming up. And I think that is, next slide. So August 1st, clinician engagement launch. The goal is to have some materials and push those out so that we're all saying the same thing about the program. And then August 18th is the line live date. And I'm always putting a plug for the brand new crisis line that's for patients and for moms to call at any time, 24/7, and highly linked with the suicide hotline and 988 now, since 988 is live. Any questions?
Any questions from anyone? I guess, again, big thank you, Dr. Wakefield, for putting this together, but also to the folks at UT Southwestern, UT Austin and Baylor College of Medicine for being the pilot sites and being fully engaged. And the goal will be to get this launched. Work out how do we do this, and again, that's why you do a pilot. There'll be you have a time period to work out the kinks. We joke a little bit that a pilot in Texas is basically doing what 4 different states would do all at once. And then doing what another 6 states would do. And so it's a very large pilot. But the goal will be to have some preliminary data go into the legislative session to be able to share that experience and try and take this statewide. Get the funding next legislative session so that in September of 23, we can start moving this to a statewide initiative. And if there's some institutions that will not be able to cover their area because of the expertise, figure out how do we still do it statewide by covering for each other for this initiative. All right, any other questions?
So
Seeing none? Yep, go ahead. I hear somebody.
Sorry, no, this will be a nice one to scale up across the state. So it's great that it's gotten started, and I suspect that you'll find many here willing to jump in and help for sure.
No, I appreciate that, Jared. Thanks. Okay. Let's go. And Andy, I don't know if you want to be the lead on this one, but the Collaborative Care Meadows Mental Health Policy Institute update on the work you guys are doing.
Yeah, well, I mean, the sort of earlier overall update kind of stole my thunder because the main update is that we're hoping someday to have a contract. So that's basically the process. So I mean, we did have some meetings since the last TCMHCC meeting with the contract leads, because there's some coordination on the collaborative care piece, because there's going to be funds that go through the HRIs for your staff and for the incentives for the health system. So we just want to kind of make sure all that kind of fit. It's going to be, a little bit more coordination, but I think we felt really good about that. I mean, we don't have any concerns. If you have concerns, you should let Melissa Rowan, who's our lead on this, know, or you can let me know if you don't know how to get a hold of Melissa. But the other thing that I think is just important to keep in mind, and hopefully gives a little bit of hope on this, in terms of some of the potential ability not just to ramp this up but to sustain it, is on June 1st. The Texas Medicaid program began to cover collaborative care, which is what we're going to be all ramping up. So many of you, may be working on this already with some of these health institutions, because there's now a way to pay for this. Just to remind folks, the logic of this is not to pay for collaborative care, but to pay for the startup costs and the technical assistance to get systems going. Because if you look at states where they have been covering collaborative care, which basically pays for a behavioral health care manager and a dedicated part-time psychiatrist for every primary care practice, can happen virtually or in person, works the same no matter what, that states that have had this for years still have very little actual availability of it. And we've researched this. We're actually doing a project right now with the Commonwealth Fund to see, some other innovative ways states have covered this. But it really comes down to, in the analysis we've been doing so far, to that there's upfront costs, and those upfront costs, while not large, are kind of create inertia in health systems, so they kind of never get around to doing it. So that's what these grants are for, is to create incentives for the health systems that we're going to be partnering with through your departments to do it. And one day we will have contracts, and we are ready to go as soon as that happens. So that's, I think, the main update I would have. And I'll put a little link into the chat for the information on the Texas, on the Medicaid. Wayne, I'm going to do exactly that. The approval by the state, I'm going to put in the thing from the website about that. So thank you. Great minds thinking alike, Dr. Goodman.
All right. Thanks, Andy. Any questions for Andy? All right, seeing none. The next ARPA-funded initiative, the Substance Use Disorder Services. Dr. Blader is not here. He's on a well-deserved vacation. I guess what I could, I don't know if anybody else wants to update. I attend those meetings on a regular basis. They are meeting every other Friday morning at 8 o'clock. And so it's good to see that crew every other Friday. They have worked through the different levels of screening and referral patterns, trying to get consistency and be able to start moving forward. I don't have the start date, but I think at the beginning of this school year to be able to integrate that screening of substance use and then linkage and to the services that they'll be providing. Anybody from that group that wants to give more details or providing any additional information?
Just to say that we are ironing up the process of screening with the different rating scales, and also incorporating that into the regular screening that TCHAT is doing, and then working out some of the other details to get ready to start. And there's some training that is already going on as we speak in the next weeks for on different approaches. So I think one is the family. What was that? The family systems theory.
So appreciate some of the team at Texas Tech that's been providing some of that training. As we looked outside the state of Texas, I think there was a realization that we have that expertise here to do the training and can support each other to move these programs forward. All right. And it's, again, a very novel approach, and there isn't a playbook how to do this, but we'll integrate it into TCHAT and learn lessons and move that forward and share it with the rest of the folks, and so that we can, and other HRIs that would like to do that in the future, be able to help provide that assistance. All right. Dr. Trivedi, you want to give a brief update on YAM, the Youth Aware of Mental Health Initiative?
I have to unmute. Okay. Can you hear me now?
I can hear you, and your slides are up.
Wonderful. Thank you all. The good news is we have launched the program, except, okay. So this is very quickly so that I can bring people all back to the same place. This is a 5-session evidence-based program delivered by certified facilitators to students in the classroom. And remind you that what the idea behind it is that the facilitators are trained facilitators who are not the classroom's teachers, and the whole classroom is engaged with it. So it's not identified students, it's the whole classroom gets a 5-hour, 5 interactive mental health promotion program. It's delivered over 3 to 5 weeks. It can be over 3 weeks or up to 5 weeks. Its real goal is to increase discussion, knowledge about mental health, development of problem-solving skills, emotional intelligence, resilience, and also mental health literacy and help-seeking behavior. So that, and then there is a lot of peer interaction also. These are all the HRIs on the left side that have joined us, and we have been having a significant number of calls individually with each HRI, as well as together on a weekly basis. The projection, there's some variability, and we are working with some of the HRIs to bring it up, but roughly about 10,000 students per HRI is our assumption. We'll see as we move forward. I think it can be done, and I'll show you a little bit of an experiment we did before we launched this for the whole state. This is what we did recently, where we looked at 33, just to emphasize the additional benefit. This was evidence-based because it was actually a result of randomized control trial in Europe with 11,000 students across 10 countries, showed clear reduction in new onset depression and suicide. What we did was in real practice here in the North Texas area, and we published this recently, where we then got deeper data from 3,300 of the students. We have done about 18,000 students in North Texas over the last 3 years, of which 3,300 we got deeper data from them. And really the real issue is about a quarter of the kids reported significant depressive symptoms, and about 22% or similar number had significant anxiety symptoms. So this is really the crux of the problem, that if we don't go proactively and just wait for a crisis, these people get ignored and then wait until there is a crisis. So that's another way of looking at this whole issue that we've been discussing all day. There have been a lot of publications from this. Now officially we have launched and we did our first statewide facilitator training last week. We have another one coming up next week, and then two in August. The slides are not moving. So this is the implementation timeline. We started facilitator trainings in July and August. We'll have one in September if we need, but the September is when we will launch this in the students. We will have a full panel of facilitators certified. We already have done 40 of them. We are accruing more as HRIs are able to send them, so that as soon as the school starts in September, we should be able to launch. We may need an additional facilitator training in January, depending on attrition, new facilitators hired, et cetera. And that, and then the launch, once it launches, then there are 3 to 4 windows that the students are able to provide, schools are able to provide for the facilitators to go in. And that is generally the plan we are right now organizing with each of the schools, each of the HRIs, and we'll really work individually. We have had a lot of calls, even up to the level where some of our folks are directly talking to schools with the HRI itself in place, so that this can be launched in a timely manner. We will get student level data on this as we move forward, and these will give us a sense of both strengths, difficulties, as well as depressive anxiety symptoms, mental health seeking behavior, and mental health literacy. And we will be able to actually show change over the period of this 3 months that we will then go back for each of the students. So I'm going to stop here. There is just a very quick idea that we've been talking about, and I've proposed this, that once you do the school program, that will really help us with the tier 2, tier 1. The slides are not moving. Am I doing something?
I'm driving the slides, Dr.
Oh, you're driving the slides. That's why. Okay. Well, thank you. So I thought I was driving. Never mind.
That's how good you were, Alicia.
Well, so we think, maybe next slide, I don't want to take too much time. I think that there is a very important thing, and that is this YAM program is ideal for tier 1, which is universal services for the entire classroom. And as you saw from the data I showed you, that really immediately creates this awareness for all of us that there is a huge need for tier 2. And then tier 3 is obviously what TCHAT provides, what then can lead into CPAN, et cetera. There is a huge hole for tier 2. And so we have developed and trained people to basically what we are calling them wellness ambassadors within the schools. If you show the next slide. That tier 2 new wellness ambassador training really is what I think will be ideal for this. If you go to the next slide, it tells you what the wellness ambassadors can do. They will be able to, basically they are now, remember, for physical health and exercise and sports, we have coaches that deliver the kind of information, identify the kinds of needs for students, whether you want to become a football player or a soccer player, et cetera. We do not have anything similar for mental wellness. And once somebody's problem is identified, unless there is a huge need where somebody says, now you need to go see a doctor, that middle group, the tier 2 one, is where YAM and wellness ambassadors will fit. They can help identify students in need, assist students and families in addressing acute needs, identify possible resources to address mental health or environmental stressors, and ensure linkage to resources is successful. I think this is really key, and we'll see where we go with it. I am going to stop here. There will be training. I can talk more about the training itself if people are interested. Thank you.
Fine. Very good. Any questions for Dr. Trivedi? I see Dr. Martinez.
Maduka, this is Octavio. The YAM data that you're going to be able to capture, will you be able to at all capture increased access or utilization of services by the youth?
We can. I think that is something that I'll bring back to this committee to see how extensive the committee is willing to let me go. But I think that is worthwhile acquiring if that is what the committee wants.
Okay. Any other questions or comments? And then Dr. Trivedi, Dr. Williams isn't here. I have your name also down by Family Intervention of Suicide Prevention, the FISP program. Were you going to provide any update on that program, or should we wait
I'm
till the
happy
next?
to. I'm happy to, and I think Luann is so good at driving slides, I'm going to let her drive it.
Michelle,
Lachelle is doing. Thank
Hey,
you.
Dr. Trivedi, you don't want me doing it.
Thank you. So go back to the first, never mind. So the developers have changed the name from FISP to Safety A. And it was originally created for emergency departments to involve three parts: behavioral assessment of imminent risk, review of other risk and protective factors, risks, and those two will then help you determine risk stratification. These three things are basically what we will train people on. So next slide. So these assessment of imminent risk and crisis or acute care intervention. So this is sessions are designed to be brief. There is a session with the youth alone, which identifies their self-strengths, family strengths. There's a feeling thermometer promoting events for suicidal or self-harm episodes, safety action plan, and safe settings. Then there is a time with the parent alone, again, identifying strengths and concerns in the family. And then both of them are brought together and they share. There is a review of the action plan, addressing the barriers to maintaining the safety plan, obtaining commitment to use safety action plan, and schedule next session. The basic principle behind this is if a primary care pediatrician is seeing a 14-year-old who's had some a concern about suicide risk, they feel uninformed about what to do. So this training actually trains them to develop the safety plan with the youth and the parent together. Next slide. So within TCMHCC, we will adapt this for implementation in primary care. And we investigators will work closely with the developers, so which is me and Laurel. So we have already had several calls with the developers. The CPAN team members will be trained on at least in our first step here, to assist PCPs when confronted with adolescents reporting suicidal risk. And following the training, our goal in this one at least is 50 PCPs will be recruited to be trained on Safety A. Next slide. That's the time. So we have already been working on this. We have created the data structure. We have also talked to the developers. We have a training plan. And next slide gives the timeline. So we are working with the developers and Dr. Williams and the CPAN teams to start scheduling trainings for Safety A to deliver. Thank you.
Is the training being done via like an echo telehealth model for those 50 PCPs, or are you doing in-person training?
So the training can be virtual or in person. It has its own approach. It sounds like it's just Dr. Wu. The training, Joan Arsenov has done this kind of training way before ECHO was born. And so that approach is the training that we are doing. So it doesn't have the kind of echo approach, but there is a regular training modules. They can be done in person or virtually.
Okay. Any other questions? Thank you, Dr. Trivedi, for pinch hitting there and doing both of those presentations. It is now about 10 after 12. Lunch is here for the folks here on premise. We're gonna, I think, let's take a break and start again at 12:45. That'll give everyone a little over a half hour to find the food, eat the food, and do everything else you need to do during the break. And so at 15 till 1, we will start. Again, encourage everyone to be here properly because the next subject is the budget for next fiscal year, and we need to have you here as we move the budget forward. And so again, we'll start again at 15 till 1. Thanks. And remember, everyone, these microphones are still live. And so and take your other conversations into the next room.
Or just don't say mean things.
Yeah.
Sure they are.
All right. All right, we are going live in just a little bit. As soon as I get I got the signal, we are going live again. Again, welcome back, everyone. Good to see everyone here. I guess for quick formality, there's been a couple people that have joined us since we started the meeting. And I want to make sure the record reflects that. I know Andy Keller is here, Dr. Borges is here, Sonia Gaines is here, Laurel is here, Laurel Williams, and I see Alan Polowitz. If there's anybody else that has joined us since the beginning of the meeting, if you'd identify yourself, again, we want to make sure our meeting notes are accurate. All right. Seeing no one else, we'll go ahead and jump back in. We're going to adjust the schedule just a little bit. Dr. Williams is traveling and she has a brief break here where she can attend the meeting. So I'm going to go to her update on the cost update, and then we'll go to the financial component. Dr. Williams, I'll turn it over to you.
Thank you. I'm in lovely Chicago right now. It's not boiling hot, so I'm sorry for everybody who's still in Texas and it's boiling hot. And we missed a supermoon last month. So we'll go ahead and go through the cost report. It should be pretty brief. Next slide. We're going to talk obviously about, that was really faster. Is that really how fast we were going to go? Okay. So we're going to just talk CPAN and TCHAT specifically, and we'll go ahead and do that. So one of the things we do want to highlight is that our CPAN Project Echo, this is across the state, all the 12 teams are doing the same topics. We had a spring session, had six sessions in the series, and there was over 914 participants across the state of Texas who were in Project Echo. And then of course, after the tragedy in Uvalde, one of the things that we elected to do was add on 2 more topics for this Project Echo. So we had 2 additional sessions. We had a lot of great team members bring up particular ideas for presentations. We ultimately selected 2. And so those are 2 additional lectures. We had a slightly different format. It was actually just a longer lecture. And we actually recorded the 2 sessions. These were from team members at UTMB related to trauma. And so what we're going to do with these 2 recorded sessions is put them up on our Texas Child Mental Health Care Consortium website. But even at very last minute, we had 70 learners across participate in the 2 additional trauma. Next slide. So when it comes to the ARPA project, one of the things that we're working on is one of the ARPA projects is to do the actual direct consultations to select patients after having a conversation with the primary care physician and still feeling like we can't help answer the question appropriately. We actually are going to go ahead and do a pilot of this project before we have the platform sort of in trait built out. And so we actually have 6 teams who have agreed to participate in the pilot and 6 who are going to wait and see how the pilot unfolds. And we are anticipating starting this at the beginning of August and sort of running for about 12 weeks or so. And then with that pilot information, we'll bring that back both to the CPAN Leadership Committee as well as possibly this team as well, so we can understand how things are going with this and what things we might need to change about it. Next slide. The texting project. So this texting project, direct messaging, for those who are wondering what this is called, we did have the pilot is complete at this point in that we had about 50 text messages come in requesting a consult. We are now at the phase of this pilot where we are asking for the providers who participated to complete a short survey on their how well that worked for them or not. I can tell you right now, without seeing the data just yet, it was a little bit underwhelming. So we might take this information and decide, what we might want to change about this direction of texting process. When it comes to calling, it actually seemed like people were still kind of preferring to call versus text. But we are going to keep working on this, and we'll get some feedback, and it'll hopefully help us kind of decide what we might need to do moving forward. The other ARPA project that we oversee, which is the suicide safety planning project with PCPs, we're still in the holding phase because we're waiting to hire the project lead. That has moved forward at Baylor. The contract is out to that psychologist that we're having lead. And once that person gets onboarded, we will kind of go back into with the other teams and get going on that project. Next slide. As a result of the changes for CPAN related to both doing direct consults as well as the PeriPan project that Dr. Wakefield is overseeing, we are going to need to add additional lines for Lantana. That's the phone system that manages the 901 CPAN line. As you can see here, there are 26 lines overall, 22 are requested for the ARPA. So the ARPA lines are both for the direct consultation. We wanted to have a very specific line that was only for, not direct consultation, I'm sorry, the texting. One specific line that people could monitor for when text messages come in, and the rest of the lines are for PeriPan. The other one that we're getting ready to show you in the next slide is that we were asked by the executive committee to go back and sort of rethink what to do instead of the 5-minute metric. So we're going to go to that next slide now. So this is a bit of a busy slide, but one of the things we're pointing out is that there's already a feature in Lantana that can create this report that you're seeing right now in less than 30 seconds. And so as we've been talking with the CPAN leadership team, as well as the data governance committee, what would be an improved metric versus the 5-minute callback metric. We have decided that what we might want to do, and we're hoping the executive committee will weigh in here, is that have an ability for us to start actually monitoring this information here, when you can look at each of the extensions, see how many calls have come in, how many have been answered, how many were missed, how many were abandoned, how many went to voicemail, and spend the next few weeks or months kind of getting a baseline for this data, because also the phone line is itself growing and we're getting more calls. And then at that point, we would be able to come back and say, we think these are reasonable metrics to make sure that we are getting to CPAN providers quickly, because that was the premise for the 5-minute callback, was to make sure that we're getting back to providers quickly. So we want to sort of look at this data and study it for a period of a few months, because we think that this might end up being more specific and easier for us to understand if there is an issue, where to maybe go in and fix the issue. So what we're asking for the executive committee is for us to allow us to work on this process and in place of the 5-minute callback metric, and then come to you in a few months with, here's some more very specific information about how we're going to guide teams to ensure that we are getting back to calls quickly and efficiently. And I see that there's a hand up. Do you want me to wait till we're done?
Why don't we take this question now and then we'll move forward? Andy, I see your hand.
Yeah, Laurel, just to clarify, you'll continue to track the 5-minute one while you're developing the new ones, correct? Or you will stop tracking the 5-minute one while you develop the new ones, which I was unclear what you were asking.
Yeah, so people are asking to stop collecting the 5-minute callback, because again, it's in of itself is imperfect. And doesn't, because of the way that the phone system works, we don't always know, and we're not keeping the voicemail. So how do we even check that the voicemail really wasn't a voicemail? Because a lot of the voicemails that we get currently are actually telemarketers or wrong phone numbers. Like, it's not a provider asking to get a call back.
I wasn't asking for the rationale. I was just asking what you were.
Yeah, so that's why, but I'm saying, like, that's why
will there be an opportunity to discuss the pros and cons of this proposal later, or how will this be acted on by the executive? Are you going to, at the end, are we going to talk about this, or what's the process by which we will discuss things like the things you're raising, as well as the things I would like us to consider?
Again, so the proposal here is to stop tracking the 5-minute.
No, I understand, but when are we going to, I'm asking, when are we going to do that? Is that, we're going to do that now, or we're going to do that later? Because I don't want to get into it now. I just want to understand what you were saying, which I do now understand. And so I don't want to interrupt your presentation to have the discussion. I'm wanting to know when we will have the discussion.
So we would have the discussion after we have some more data, so we can come back to you and say, here is the data, here's what we found, and here's what we recommend.
What I'm asking is, when will we decide whether or not to let you stop tracking the 5 minutes? Have we already decided that?
No,
Okay, well, that's what I'm asking is when will we decide to grant you what you are currently asking for right now? Are we going to do that now or are we going to come back and do it later? And my assumption is we'll do it later so you can keep doing your presentation, but I don't know.
I don't know either. That's a good question.
Andy, this is she asked that so I need to make a motion for us to vote on for this because she's asked. So I think the motion is to continue tracking the 5 minute, but to give CPAN the opportunity now to explore the other data. Is that
That's
correct?
different than what I heard Laurel say. I heard Laurel say, stop tracking the 5 minute and then take 3 months to come up with a different metric that then we can then report on that. Which, just so everybody knows, I will vote against. Because I think you should continue to collect this flawed metric until you have a better metric. Because a metric is better than no metric. And I also don't think what you measure here is the same thing. What you measure here are all the little wonky things around how phone answering systems happen. But the beautiful thing about the 5 minute metric is it makes sense to normal people outside of this process. So we're going to need to have some metric that makes sense to normal people who don't spend all of their time thinking about this, because that's who this metric's for. It's not for you all to do a better job. You all need other metrics to do a better job. But this metric is for people who don't actually care about us at all, who are going to look at one thing and are going to try to gather how good a job we're doing, which for its lack of perfection as a data element, the 5 minute one does reflect quite well on what you all are doing. So I'm not saying you shouldn't have a better one, but you're going to need one that makes sense to normal people, is meaning not us.
So maybe Laurel, and I know this is kind of in the midst of your presentation, maybe we do a little stop here, intermission, and take care of this issue, and then we'll move forward in general. And to make clear, can you make clear what your proposal is again, and just state it, and then specifically noting that the difference of
Dr. Pliska, can you mute for a minute?
Yeah, we'll try this again. All right, the echo's gone. So, sorry, we had a rotating echo where we unfortunately had to hear me say the same sentence about 10 times there. No one should have to go through that. You just got admitted to purgatory, right? So
it sounded good.
So let's stop here for a second. And then we'll continue with the rest of the presentation. But the question that I hear is a difference of how do you gain this data and decide whether you're going to continue the 5 minute metric or transition to this. What it sounds like you said is stop now and transition. What I hear Andy say is do both in parallel for a little while, and then once you feel comfortable that it's a good metric, then we can come back to the executive committee and with that data make the decision of which of the two metrics we move forward with. Anything else that you would like to say about that, Laurel, related to make sure we're clear in the understanding?
I think that is accurate. I think, again, as we've been working and using the phone line, the 5 minute callback metric, we just weren't sure was actually getting at I think to Andy's point, it's very clear, like I agree, you don't want to have a wonky one, but at the same time, we weren't sure that it was really helping us understand that we were getting to people quickly. And that it's for the executive committee to decide for sure.
And how difficult would that be for you to do those two things in parallel for the next several months and then come back to the executive committee and say, this is what our experience is, and then make that informed decision of going one way or another?
I don't think it'll be this, because this report actually just self-generates in Lantana. So you don't have to create this report. You just literally ask it a few questions and then you have it spit out the results. So we would need to look at those results and decide what metric we'd want to tie. So that's not itself difficult to do.
Okay. Steve Pliska, I see your hand up.
So now on this screen you're showing us right now, the 5 minute metric is not there, right? That you're talking about.
The 5 minute metric is not something Lantana can do. We have to manually download every single month, look at all the calls. We have to check I mean, right now we're not keeping the voicemail. So it's people saying that, no, that voicemail was not actually a paid PCP. It was a telemarketer, which is actually the most voicemails we get are telemarketers leaving us a message.
But
we were just discovering that it wasn't really helping us answer the question of, are we getting back to people quickly?
So you're doing it, but you're finding it very arduous and not accurate. Do I understand that correctly?
Yeah, so that's the arduous in part. This actual thing you're seeing right now is very easy to generate.
Well, right, yeah, but this has got nothing. We shouldn't be distracted by this because there's the 5-minute network is nowhere on there, right?
No, it's not.
Okay, all right. And then so you have the 5-minute metric that then you end up saying what exactly, that X number of calls were returned. You try to say that X number of calls were returned within 5 minutes.
Yeah, so you try to say that we've been able to call, but again, the vast majority of the voice messages that are left for us are actually like telemarketers. They're not PCPs. So then you have to say, well, there's not really 5 of them. It was actually 1 of them. And yes, they were called back. And the problem is that you could call back to a different number. So you can't see it on Lantana that you called back, because again, the number that the PCP said, don't call this number, call this other number. So when you call out, it doesn't look like the numbers have connected with each other.
Right. And just so everyone's clear, what you're talking about, you're not talking about the phone being answered. You're saying on those X% of time that it goes to voicemail, how often is the voicemail returned?
Correct.
So how difficult would it be to report just the percent of time it goes to voicemail?
Yes, we could. So Trait can tell us how many times that it went to a voicemail. Yes.
Because I think, Andy, to your point, I think what you're worried about are a bunch of calls going to voicemail that aren't getting returned to the next day. And what we want to know, I think from our standpoint, we want to know, no, only 3% of our calls go to voicemail. Right now, we don't know we don't know accurately what happens to that 3%. And so I guess another way, Laura, I'll get your input on this. What if you change the metric to start simply reporting percent of calls that go to voicemail come back to us with a proposal to figure out what happens to the voicemail in the future. I don't know if that solves the problem or whether that just complicates things.
So right now we're not saving the voicemails. So if we wanted somebody to be able to go back and say, well, did you really do it? We'd have to ask for people to save all the voicemails so you could go back and check that, yes, of those 5 voicemails, only 1 of them was a physician asking for a call back.
Right. And that you're not doing at present.
No, we're not saving. So we're not saving the voicemails. We're asking people to go back and look of those calls that went to voicemail. How many were you able? Because they have to go manually look, because you can't just tell by looking at Trait. Right. So, at Lantana. Now we do have the 30-minute callback, which again is the one that honestly the one that we see as the extremely important one, is that if you want to speak to a physician, we will call you back within 30 minutes if you want to speak to a physician. And we hit that metric by 98%. So this 5-minute callback is, they could be saying, hey, call me back tomorrow, call me back. It's not sort of like, hey, call me back. And, so we know in Trait that if they've asked to speak to a physician within 30 minutes, we're doing exceedingly well with that.
Because that's logged in Trait, because this person has come in and put their note in. All right. Correct. So that's pretty solid.
Yes.
Do you know off the top of your head what percent of calls end up going to voicemail?
Not right now, but I could certainly come back to that.
Because would you say it's probably quite small?
Yes, it's very small. It is.
So Andy, I'm not sure. I hear your concern, which is we want to know we're getting back to the docs, but I think it may be that those voicemails are such small outliers that it may not, maybe that's the data we should look at first before we make any kind of decisions one way or the other. Because if only 2% of our calls go to voicemail, we don't really have that big a problem. We want to make sure, because they only go to voicemail, if every line's full at a particular site? Or is it are they full statewide?
No, so it's within that ring group. So it would be a voicemail to Baylor, for example. It wouldn't keep ringing across the street.
Okay, so, and then each site then is responsible for going in and checking their voicemail and responding to it. And right now they just do it and they delete it if it's irrelevant. They write it down, they call back, delete it. That's what they're doing currently.
Laura, why did we set it up with voicemail? Can you just jog my memory?
Sorry?
Access centers typically don't have voicemail function. They actually measure their wait time based on when you pick up the phone, no matter what. So I'm just asking, why did we set up voicemail function to start with? Why we voicemail?
I think because each team, we didn't have it set up, so it was not a round robin that if the Baylor team wasn't available, it would automatically ring to some other team. We did envision that maybe every once in a while the phone wouldn't get answered, so we need for people to leave a message.
So
and we don't say
people.
that. So yes, that's the answer.
We have two people answering the phone in San Antonio. So if we have 3 calls at the same time, it's going to roll over into voicemail. That's apparently is fairly rare. I mean, I could ask my people exactly how often it happens.
Correct.
All I'm saying is that typically access centers for health systems are not set up, at least the more proficient ones are not set up with rolling into a voicemail. They're set up and staffed to answer the phones within a certain time period. That's what I'm saying. So you probably wouldn't be able to find functionality to track voicemails because that's not typically what, how it's set up.
I think this metric was created before we really understood the phone systems and when we got a phone system. So to your point, it was decided before we actually picked a phone system.
Yeah, so I would just say, I really appreciate Steve's discussion and Hisham's as well, but I think my main feedback here is that what you're showing on the screen right now is not an alternative. This is meaningless to normal people. So I think that if we're going to have an alternative, there needs to be a presentation that says, we're going to, instead of report 5 minutes, we're going to report the percentage of calls that are abandoned, which if I read this data you're showing, which perhaps is dummy data, I hope, but if I show this, it looks like over 50% of calls, just under 50% of calls are either missed or abandoned. So it looks actually like quite a high abandonment rate in the way you're presenting it. So for those of you out in TV land, this is not the real data. But I think that we need to have a proposal made for normal people, not those of us who live with this. So like there needs to be a slide shown that says, instead of 5 minutes, we're going to show the percent abandonment. And by the way, the percent abandonment is under 5%. And that's what we need to do. I will also say too, I'd really like you guys to think through this a little bit more, because there's no reason why no one needs you to say voicemails. I mean, we don't not trust you. I mean, if the people at one of the HRIs, they're going to listen to the voicemails each time because they're going to see who they missed. And if 5 of them are telemarketers, ignore those. I mean, there's no reason to track the telemarketers. So I think the way you're describing this is making more work than is reasonable for you all to do. I mean, really, and if there's only a few that are missed, why wouldn't we want to know what happens to those? So, I mean, because the burden wouldn't be that high if you're only missing 1 a day. So like once a day, you make a log about like what you did and you have a little Excel spreadsheet. I mean, so I just think this needs to be thought through in a more systematic, I'm sure you have thought it through in a more systematic way, but it needs to be presented in a more systematic way, I think, because while this may seem like a small deal, this is huge. I mean, I'll tell you when we presented on this the first time, or whoever presented, I think you presented, Laurel, and people let us know, legislative offices let us know how cool it was that so few that they had the 5-minute thing. So like, that's a powerful piece of data to the people who we actually are accountable to on the outside world. It may not be all that useful to y'all, but I think that you can come up with less onerous ways. There's absolutely no reason to be doing all the things you just listed. And if it truly is as small as you're saying, then I'm pretty comfortable personally, having people track it. I mean, like if it happens once a day, that doesn't seem that onerous. And if it's happened to you a lot, well, then frankly, you deserve to track it more because y'all aren't answering the phones. So, I think that that's the kind of, framework we need to have a proposal to respond to. And when we present it publicly, like in this forum, we need to show it that way because most of the people watching have no idea what we're talking about and could potentially misinterpret data like this if it was presented without the additional clarity. So that's my request to you, is that we just keep doing what you're doing and come back next month with something that appeals to normal people as opposed to those of us in this strange little world.
Andy, you make it sound like we are inventing how access centers work. I'm going to push back a little bit. It has to be feasible too. So setting the expectations that can be met is also going to be important. You know, all of us in health systems, we report on how our access center function and people understand it just fine. I think we just need expectation that can be met as well.
Yeah, Hisham, I'm not saying to do it.
I think we can go back.
I was just saying, do it, present it in a way that makes sense too.
That's fine. So Andy, it's totally fine. We will go back to the data committee and back to the CPAN leadership team with this feedback, and we will keep working on it. So we don't need a vote today because we're going to keep working on it. Okay. That's easy.
I think so. Thanks, Laura. You want to go to the next ones?
Yeah, so the next one, we just wanted to highlight just sort of growth between the first year that we were doing consults, August 20 to 2021, when we had the data in trait, and then July 2021 to June 20. So the blue is the first year, the red is the second year. So we just wanted to highlight sort of the growth that we've seen across the state with CPAN in the last 2 years. So the number of completed consults, the number of specific patients that were primary care doctors or providers were calling us across the state, as well as the reasons for contact. So as you can see here, we sort of had growth in all areas, and we thought that would be interesting for the executive committee to see. Next slide. And then again, this is looking at the year-to-date growth in referrals. So what types of referrals are we providing to the PCPs across the state? And again, you can see the blue is year 1 and the red is year 2. Great. Next slide. And then we've certainly had people ask questions about what types of issues or concerns are providers calling us in about. And so we look to see what are the sort of top 6 diagnoses across the board when it comes to the specific disorder or diagnosis, as you can see here. ADHD and depression continue to be sort of our highest numbers, but we also do hear a fair amount of people with anxiety and as well as autism, and then smaller but still significant bipolar and post-traumatic stress disorder. Next slide. So we're now just going to move very quickly through, not quickly, but next to TChat. So the school portal. So as we've talked about, the teams are going to start using the school portal so that the referrals will come in across the state in a similar fashion. The portal itself is already live. Some of the TChat teams have been using it, but teams that are going to start using it for this new school year. What we're going to do is allow for the school staff to help, their administrators to help enroll their counselors as they come and go. That will be the first thing that they'll be able to additionally do. We also will have the ability to have a secure document transfer process so that when we need to transfer documents back and forth to the school, we can do that. That will launch in August of 29th. And then we will have some additional insights and reporting that will be available to the school district at a population level. So it's not about specific youth. But again, a lot of the teams already provide this information in a sort of ad hoc, different format. So now going across the state, all the schools districts will be able to see a similar view as far as what types of, how many referrals their schools are providing, and sort of how many students are being served. Next slide. The next couple of slides we're just looking at is the data from this last academic year only. So when you look at this last academic year, again, you can see this is the total number of enrolled unique patients each month. And overall, we continue to have growth in the number of enrolled students. We definitely have that sort of bimodal distribution as we get into the winter break. You see a decline. And then once again, as we move towards summer, you see again that other decline. I do want to point out here, though, that TChat remains open across the state, even during the summer. So each of the schools that we partner with still continue to have processes that if they have a student that they have known that has an issue or concern, there's still a way for them to get a TChat referral and for a child to be seen over the summer. So we do not stop TChat services over the summer, but we do obviously see usually a decline in the number of referrals and then therefore number of enrolled patients. Next slide. And so corresponding to the number of students, as you can see, we've continued to see the number of sessions. So this is an individual therapist and or physician seeing a TChat patient student. You can see here, these are the number of encounters starting in August up to the end of this academic year.
Laurel, can we just make the point here that the enrollments or the new referrals go down, but the sessions still stay quite high? So there are quite a few kids in the summer.
Yes, so yes, we continue to see students even over during the summer, correct. Care does not stop because of the summer. So as you can see here, this is the end of June, we still had 46% of the students were still in an active status. 46% had been archived at that point, and 7.9 were in a transitional state that they were moving to archive. They just had not finished the final step. We do anticipate, again, this is a clinical service, so we want to be guided by clinical care. But we also have set some parameters around if somebody is sort of stopped coming to the services, we've allowed for teams to sort of transition, archive them. Families can always come back and get a referral if needed, but we are hoping that we can kind of have a better sense at the sort of next meeting, how many students were had been able to go all the way through a TChat service for this past academic year. So we probably will have a better sense of that in the next meeting in September. And when you look for the reasons for why, and those youth that have been archived, you can see here that for about 2,350, that was that they were completed the service. That does not mean that their care was completed and that they might not need a referral. They might still need a referral, but the TChat service itself, both the family and the provider agreed that the service could safely end. 494 families declined to continue the service. And I can't see this, I need to move my face. And then we had 779 who had been not coming back to the service. So we're going to continue to follow that and see where this information takes us. That's all we had today. We were trying to be brief. We knew this was a busy agenda.
Very good. Thanks, Laurel, for putting all that together. Any questions for Dr. Williams? All right, I don't see any hands. So thank you, Laurel, and good luck with your travel, enjoying the weather in Chicago versus here in 105-degree Texas.
Sorry to hear that. Well, I'm going to go back and write more test questions for the child pride. Dr. Goodman, that's what I'm doing. Working hard at the hotel.
Very good. Thank you, Dr. Williams. All right. Actually, why don't we finish these other quick updates and then we're gonna go up to the budget. Steve, anything on CPWE that you want to update us on? Steve, you're on mute, my friend.
We are continuing to work on improving reporting of metrics, particularly around exactly how many residents and faculty are funded at each LMHA and non-LMHA site. As you know, residents rotate frequently. There's often, you got to distinguish between a resident being funded and versus the time the resident is in the clinic. So one individual resident has certain mandatory educational activities, so they're only available probably for about 80% of 0.8 of time that they could be in the clinic. So if there's if one resident is assigned to a clinic for a month, there's going to be 32 hours available. So we got to make sure that distinction's clear, so we don't get into issues about how many are funded versus the expectations for the amount of comparison to the amount of patients being seen. And another issue that we did not anticipate, we certainly should have, those of us who worked for residents for many years, is that last year many of the residents did not return their surveys, which is part of the metric. And it means that we are going to have to get training directors more directly involved in doing that. So I moved the CPUE meetings up to monthly. They were every other month. And Lachelle and David Lynch and I are meeting on Friday to kind of reformulate the reporting template that is done monthly so that we can kind of collect this. It's a little easier to understand, a little easier for sites to report the data in the way that we need to. And so we'll continue, continue to kind of work with that so that we meet we'll have all the data certainly for this year in regard to metrics, particularly around the issue of if questions come up about, how many patients are being seen per FTE, we want to be able to give an accurate answer to that question.
Okay. Very good. And you want to, and then the last item on that part of the agenda, the Data Management and Governance Committee update, anything on that item?
We don't have anything really
Alex?
particularly important to report at this point. All of these issues around, like such as Laurel was reporting on, we're looking at all those issues on a weekly basis. And we're probably over the next, I think if not next month, maybe the month after that, the data committee may come forward with some suggestions to kind of further improve the reliability of our data.
Okay. All right. Any questions for Dr. Plitzka? Seeing none, let's jump back up then to item number 5 and talk about the budgets. And Michelle, I'm gonna hand it over to you.
Jonathan.
You hand it over to Jonathan, okay.
Do you have the slides pulled up? So I'm Jonathan Lewis, for those of you who haven't met me. I'm Finance and Contract Manager at UT System. Today we're gonna be talking about the review of the 22-23 biennium budget. And so what we did here is looked at what folks are expecting to spend for the remainder of FY22, and then looking at surpluses there and seeing how we can redistribute those for needs expected in FY23. And so important to remember here, these funds here presented in this presentation are primarily GR, general revenue, and we're not talking about ARPA here. ARPA does come in at the end about TCHAP, but it'll be clearly marked ARPA. So on to the first slide here, just a few highlights of what we saw. So HRIs are forecasting to spend about 45.6 million in FY22, and then have requested to spend 47.9 million in FY23. There was a unexpended balance of 11.5 that people are expecting for 22, which will be available to cover that increase that's being requested in FY23. So, and then, as many of you know, we were appropriated an additional 5.8 million for TCHAT through a budget execution with LBB. That brings the consortium's total available GR to 124.3 million. Based on the revised budgets that folks submitted to us just last week, the ask comes to a total for the biennium of 123.1 million, which represents a 3.9% increase in where we were at before. So now I'll go through each of these by program. You can see how we get to that 11.5 in unexpended balances. So TCHAT is expected to have about 5 million in leftover from 22. You can see CPAN has about 3.1, and then both CAP and CPUE also have some surplus that we'll be able to use in 23. And then moving on to the next, we'll talk about in FY23, the request that we received from all of the HRIs shows an increase in all of the programs except for CAP. And I think a lot of that has to do with the timing of CAP fellowships. And then particularly I wanted to note here the TCHAT budget. So folks have been asked to expand TCHAT statewide a lot sooner than folks had probably intended to originally. So that budget has definitely increased quite a bit. And as you can see, we've already increased the FY23 budget here to include the additional 5.8. So the increase for TCHAT is only comes to about 8.3 after considering that additional funding that was allocated. And so folks are proposing, again, on TCHAT, that it would cost about $39.4 million to do the work that we've been asked to do for TCHAT for this year. So moving on, we have the variance between what was the approved budget for LBB versus what the proposed biennium budget would be based on the submissions that we received. And for reference of those that don't know, the anything over 10% of variance of what LBB has approved needs to be sent to LBB for review. And so you can see here the proposals would mean a reduction in CAP, a reduction in CPAN, and a small reduction in CPWE. And then the increase in TCHAT, and again here, that TCHAT approved, LBB approved amount includes the additional 5.8 million. And then there's an increase in requests for a research budget as well. And just also to note here, these totals do not include the external evaluation and administration funds. These are just the program funds that are received by the HRIs. I can move on to the next piece, just breaking this down, same formula down, but by HRI. So you can see again where the surplus and deficits come from that is in 22 that allows us to roll over into 23. I'll skip again to the next slide, talk about what folks have requested in FY23. You can see just about everybody is requesting some form of increase. And again, a lot of this has to do with the additional needs for expanding TCHAT. And then finally, I have a breakdown on the last slide here of the TCHAT funding in particular. So again, going back to that 39.4 million is the amount that folks reported that they would need in FY23 for the statewide expansion efforts. The breakdown of how we're getting to that number is below. So you have the existing amount of 25.2 that was already allocated to TCHAT. The unexpended balance from FY22 is 5 million. It's being rolled into 23. We would need to roll an additional 3.4 from other programs into TCHAT. And then again, that 5.8 million that was provided by budget execution. And then I also included here the ARPA TCHAT expansion dollars that were already previously approved. So that 8.3 million is included in this total amount that folks will have available to use for TCHAT expansion. And that concludes the presentation.
So I'll start off with questions. Maybe go back to the budget change slide.
For the LBB approved?
Yeah, and then, yeah. That one right there, yeah. So with Kosh, and I'm trying to remind myself, is it a line item in the budget? Is that if it's above 10%, or are we obligated to go to LBB for that line item too? Okay, and that increase, I think it'd be good to give some background on why that line item has gone up 36%.
The primary increase is for trait storage costs that were not accounted for previously. And then I think some of it is build out cost as well. I don't know if Dr. Williams is still.
Because we've expanded, we're continuing to expand TCHAT statewide, that has increased data coming into the system and increased storage associated.
Yeah, and so as we go from 40% to 100%, which wasn't the plan, there's additional cost there that pushes us into the above the 10% allocation, right? Okay. And then on research, we're above by 1%. And that may be something that we need to work through to get below that 10% by managing the budgets a little bit. So we're not asking for that increase. I think it'd be probably behoove us not to exceed that 10%, and then build in for the next biennium the dollars that we need for where we want to be related to that full research project. But I'm happy to hear back from other folks. I just want to make sure we have a very succinct message that we can provide to the LBB related to the change in the budget to make sure it goes through quickly. Any feedback from anybody?
Do you need a motion for anything?
So actually, I was about ready to go there. So what we need probably today is an overall motion that this is the base. We're going to have to do some fine tuning. We're trying to put this together very quickly so you get what you need in order to get budgets out. But there's a little bit of adjustment that needs to take place in order to finalize. And so if we had a motion to move forward with this budget with the understanding that in discussions with the HRIs, there may be some small adjustments in order to get us to where we are. That's what we did last time. The other thing, I have a motion by Alex. The other part of this is that there's some additional conversations that'll take place related to the next biennium's budget and some of those other things that we need to do. And like last time, we did that after we voted out the base budget. So again, you guys can get money coming into you and get going before your the fiscal year. Jonathan, is that accurate?
Yep, I think timing wise, we just need to be able to move forward before the end of this fiscal year. And so getting that approval now would allow us to.
So it's an approval with adjustments that will be made in negotiations with the HRIs. And I have a motion by Dr. Vo.
I just have a quick question before we vote.
Yep,
we all submitted our proposed 23 budgets. Are these just all, we can assume these are all built into them, that they weren't, that's what we asked, just they're all just put together. And we'll go back and, as you say, but right now, whatever we all asked for FY23, or these shifts, the slide you showed broken down by HRI, those are just what we asked for.
Yeah, there were a few modifications just based on some misunderstanding of what needed to go where, but
in other words, if we didn't hear from you, Jonathan, that there was a problem, what we submitted was fine. Is that what you're saying?
Right. Mm-hmm.
Yes.
I'm good. Okay, thank you.
And again, Steve, with that understanding that I might have to go back to you and say, I need to adjust here just a little bit based on the research component or any other things that get brought to our
David,
attention.
you can call me and give me more money anytime you want.
Yeah. Very good, Steve. So I think Michael, did you second the motion? So I have a motion by Alex, a second by Michael Petrarca. Any other conversation? All right. Hearing none, I'll call the question. All in favor of approving this as the base budget, understanding that some small modifications may take place based on some of the nuances that we need to adjust to, signify by saying aye.
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 All opposed, nay. Did anyone abstain? Hearing none, it is approved. All right. And then Michelle, is there anything else we need to vote on?
Not vote, but just know, once we finalize these budgets, we've got to put PIA amendments in place. And so we'll be reaching out for another round of contract amendments. So let your departments know that's coming. We need to put those through pretty quickly.
Our goal is to get the contract amendments done as quickly as possible because we have to give the coordinating board a copy of those contracts prior to them transferring the money.
All right. Are there any other questions? Shannon, I see your hand.
Thank you, Dr. Lakey. I have a related question that's a little bit different, and this may be a future conversation, but we've kind of started kicking off the FY24-25 budget cycle. And I didn't know if this entity will work with the coordinating board in terms of what their LAR looks like, if they'll include any requests on our behalf, or if we need to have those conversations totally outside of the coordinating board with leadership offices. So just wanted to start that conversation at the right time.
No, I think it's a very good question. And so for those of you that aren't involved in legislative processes, usually if you're a state agency, you have a legislative appropriations request. You provide it to them, to the legislature, and then you follow that. We're not really a state agency. We dovetail into the Higher Education Coordinating Board. August, late August, September, usually agencies meet with the LBB and the governor's office representatives to talk about what their LAR request is. Again, since we're not a formal state agency, that doesn't happen for us, but the Higher Education Coordinating Board will be testifying then. And so we're working through kind of what our role would be in those hearings. In the meantime, we are working with the leadership offices to let them know what our request would be and what those needs would be. On both the Senate side and the House side to try to think with them what they would direct us to be, the direction that they want us to follow. And so, Shannon, I don't have that fully worked out yet. But we are, again, having meetings set up with some leadership offices to get their direction, and then we'll work with the Higher Education Coordinating Board to get their direction on how they would like us to make our budget needs known. Does that make sense, Shannon?
It does. And it sounds like we may not necessarily be part of the LAR for the coordinating board, but possibly just using this budget season to have conversations with leadership in terms of what our needs would be.
Yep. And it sure would be nice to be able to do it the way that it happened last time, where we were able to identify and get a lot of those things built into a base budget. Now that's, maybe that's a bridge too far, but that worked out very well last time. I think everyone would like it to work that way for them. But again, we will work with those offices that are in leadership to make sure that we are doing what the legislators want us to do in this kind of unique process that we have.
Thank you.
Danette?
So yeah, a couple of questions. One on that front in regard to whether or not the funds could be built into the base budget, because that is a favorable situation when you get that. Last session, were the funds that were built into the base budget kind of level spending funds? Was it sustaining the program at kind of the second year of the biennium? Is that what those funds were doing? I'm trying to remember. It seems like it's been a long time. Okay.
So we provided them the dollars we needed to sustain service levels at the previously agreed upon level as we ramped up the programs. And they built that into the base budget. Again, what we're looking at here now is ramping these programs up. And then the dollars we'll be asking would be to sustain those programs for statewide TChat, statewide CPAN, moving forward. Now, it's a little bit different because we have a combination of ARPA funds and GR funds, and then this budget execution. And in our hearings, we remind them that there's a little bit of a interesting play of those different pots of money that they need to take into consideration as they want to continue these programs.
Yes, especially as those ARPA funds run on a different time frame than we're typically used to in terms of those rolling out. Now on what about the statewide behavioral health coordinating council? Do you take the proposal to them and have a conversation with them as they give consideration to the state behavioral health funding?
You want to talk about that?
We provide information to the statewide behavioral health coordinating council about our budget and about our programs. And I just received an email the other day. They do want to know information as well about LARs. So we try to coordinate as much as we can with all of the other agencies that submit information about behavioral health spending in the state.
Okay, great. Luann, you're on that, aren't you? On the council?
Mm-hmm.
Okay, so that's good. I just think it, given the importance of that coordinating council in terms of taking a large statewide look at behavioral health services, ensuring that we're staying on track to addressing gaps and all that it entails, it would be great if it's really clear that that the necessary deliberations have taken place within that. And I think Sonia had another meeting, or she probably would have been asking this question. So
I'm here.
oh, there you are. Okay.
I just popped in, so I missed.
Okay.
It's like coming in the middle of a movie. I have no idea what you were talking about.
Okay. We had just had a nice presentation about the budget for the closeout for this year and for next year, as well as beginning the conversations about the LAR process. And I had just asked, there was conversation about how the Higher Education Coordinating Board might be involved, whether the funding necessary to sustain current level of services in the next from the next legislative session would potentially be built into the base budget. And then I just asked a question about whether or not the the budget proposal would go before the statewide Behavioral Health Coordinating Council as well.
Okay. I do know from talking to Dr. Harvey, they're planning on scheduling that in August. Normal, for those of you that don't know, we have been directed by the legislature to review any exceptional items that are behavioral health. And so normally we have a process where the coordinating council members review and they get presentations of the proposed items. Some of the activity that takes place there is looking to make sure there's not duplication of effort, or that there's it's something that meets gaps that are identified in the strategic plan, that sort of thing. So that meeting, I believe it's going to be scheduled in August. It's not on the books yet.
Any other questions? Dr. Wakefield?
Yeah, Dr. Oki, I have a little, so when will we start that discussion with you guys about the 2024, 2025? And I asked because Tech specifically requested additional TCHAT expansion dollars and ARPA funding. And so we did not request in this additional GR funds. And so it will become somewhat complicated to look at project those needs. And I just want to make sure our regional expansion is included in the GR request.
Jonathan?
So you all have submitted to us FY 22 or 24, 25 budgets. And that should include TCHAT, full statewide expansion. So that is what we will take when we consider for next session of what the ask will be.
Mm-hmm. Yeah, and so it is very complicated because you have ARPA, GR, budget execution. And that's why these ongoing conversations with elected leadership are going to be very important, and mapping out these are the things you want us to do, and this is how it's put together right now. And whether they want to put additional ARPA dollars in, or if they want to do GR dollars, that'll be their decision. But in order for it to be a whole, you have to have a combination of those different pots of money to make it happen. Okay. Other questions? All right. Well, I think we have completed all the items on the agenda. Is there anything that we need to, that I missed that we haven't finished? All right. Well, again, thank you everyone for being here, either in person or spending your day in front of your computer and being part of this conversation. Again, I want to thank everyone for all the hard work to roll these programs out. Again, a lot of attention to them right now. A lot of work for us to do, but again, you guys are doing a great job, and let us know how we can support you. All right, with that, we're done.